which you can see, like examine the skin of the patient, the glands, okay, if you have some enlargement of thyroid glands, okay, which you can obviously see when through your examination, your hair, the color of your hair, the pale eyes. So everything will indicate certain deficiency of certain nutrients. You would have studied in lower class all the different nutrients and what are the clinical symptoms. So especially when you're working in hospitals, so you should be able to see when you're seeing a patient, you're observing certain symptoms, you should be able to identify, okay, something is wrong with this patient, and try to correct the, you should provide the nutrition need of that patient. Okay, so then comes the clinical, after clinical assessment is the dietary assessment. So this, there are so many based on the patient's food intake and what is the requirement, what is the gap. So there is always a gap we find. Okay, there must be a recommended dietary allowance, but actual intake must be very less. There must be some gap which patient is not able to have. There may be various reasons. It may be because they are not able to swallow, or some denture problem, they are not able to chew the food properly. It can be anything. So we have to assess the dietary intake and try to compare with what is the recommended intake and what is the gap and how you can fill the gap through proper nutrition care. Okay, that is why we do the assessment for the dietary assessment. Then comes the economical assessment. So for which we have to be looking into the patient's economic status. So we cannot just plan a nutrition intervention with planning with very costly supplements. Okay, we have to, based on the patient's economical constraints, we should plan the diet accordingly. Okay, it should be a patient-centric approach. Okay, then you should also look in the social assessment, and then comes the functional assessment. So functional assessment is to do with how active they are, whether they are bedridden or they are able to do very sedentary life, or they are very active, or they are going to gym. So all this physical, the functions has to be assessed before providing the nutrition. Okay, the needs varies. So all these parameters has to be looked into. Then comes the body frame. Okay, the frame size varies. Like if you see the Western people, they are very tall and hefty. Their frame is large frame, and Indians, they are medium frame. There are short frames are also there. So this is a calculation for which we will be able to assess the frame size of an individual based on the wrist circumference. Okay, so height in centimeter divided by the wrist circumference will give you the frame size. So we have to compare with which frame size they belong, and we have to interpret whether they are large or medium or small frame. Coming to the heights, all of you know it should be measured correctly, like they should not wear shoes and all when we take the height measurements. And weighing scale should be a calibrated weighing scale, so that whatever the weight you are looking into or assessing should be correct. Okay, so this is a very important thing, height measurements. So sometimes, especially in ICU, CCU, we would not be able to ask the patient to stand up. So for which there is an approximate calculation of patient's height based on certain body measurements. For example, patient is lying on the bed, you can use some measuring tape and try to calculate the approximate height of a patient. Or we can also use the knee height. There's a formula for which we have to incorporate the knee height, and we'll be able to find the approximate height of a patient, as well as the arm span. So all this, especially for children, when you check the height, there we have to use the height scale. There are growth chart which we have to use for children especially, and compare how is their growth. Okay, so it's a very important period of children, so that they will attain that height. Okay, then after certain age they won't grow. So it is very essential to provide adequate nutrition, calcium, protein, whatever, all the nutrient has to be met in the children's diet. If they don't grow to their stature, then they will be stunting. Okay, so we need to compare with the growth chart and see that we have to monitor that the child is growing adequately. Okay, this is the arm span. We have to we can calculate the approximate height. So for adult, you have to -2 centimeter the arm span to get the approximate height. Okay, for children between 10 to 12, arm span is the same to the height. Okay, and under 5, we have to add 2 centimeter to the arm span. So this is the approximate calculation. This is the knee height we have to measure and incorporate into this formula to find the approximate height. And the other one is the demi-span. So you see that the sternal notch and you have to measure the distance and incorporate that measurements into this formula, and we'll be able to find the approximate height. And weight is a very important tool, we say, especially for children. Okay, so I just ask you, what is the birth weight, normal birth weight? 2.5 to 3. 3 is the birth weight. So we have to monitor, like within 6 months, they are supposed to double the weight, 1 year, triple the weight. So we have to monitor very closely. And weight does not indicate certain times the correct example. When patients are overhydrated, patient is a renal patient where there is a lot of fluid, so it may not indicate the nutrition status. It may be a normal weight, but patient, it may be because of the fluid accumulation. So we have to be very careful into all this when you check the weight. So all of you know this BMI calculation, weight by kg by height in meter square, and we have to, the normal is 18.5 to 22.9 is a normal BMI, and we need to interpret the height and weight based on this based on this formulas. Okay, waist hip circumference we calculate mainly because of abdominal obesity. Now abdominal obesity is become very common in India, and this is a very important factor which will increase the diabetes, occurrence of diabetes and cardiac disease. So more and more fat accumulation on the abdominal area is a risk factor. Okay, a ratio more than 0.8 in women and more than 1 is a risk factor. So we need to assess that and intimate to the patient and counsel accordingly. Then comes the head circumference and chest circumference. So we need to, especially for children, we do this measurements so that their growth we can monitor. Okay, so this is the ratios of mid-arm circumference by head circumference. So these are the normal, and what are the things, like if it is a grossly malnourished, what is the measurements it is written. Okay, so this is the growth chart. All of you know this. So we need to interpret the patient's actual weight with this chart, and we have to see that whether patient comes under underweight or overweight or normal nourished. Okay, so this is the assessment form that we use for pediatric. The main thing which we use is the Gomez classification, and we use the Waterlow's classification. We look into the patient's diet intake, comorbidities. So based on all this, we will be able to categorize the patient, whether they are severely malnourished or moderate or normal. So all this we'll be able to based on scoring the patient. So we should know how to score the patient. So the Gomez classification is a current weight into 100 divided by the expected body weight. So we'll be able to calculate the Gomez classification, and height for age is the Waterlow's classification. Current height into 100 divided by the expected height will give you the Waterlow's classification. Okay. So this is the percentile. Okay, so percentile, when you check the patient's height, weight in the growth chart. So this is the interpretation based on the percentiles. And so between 3 to 10% needs further investigation, and between 10 to 90 is healthy for most of the pediatrics. Okay, so this is how we interpret. So weight loss is a very important thing. So when a patient is losing weight, it's not a good sign. Okay, so how to calculate the weight loss percentages? On the numerator, you have to put the how much weight patient has lost divided by the previous weight, and into 100 will give you the weight loss percentage. So when patient is losing weight, we have to ask them, like, maybe many reasons into that. So we have to check with the patient. And this is the adjusted weight for amputation, especially when patients are coming with a amputated leg. Okay, especially the diabetic patients, certain legs would have been amputated. So how to calculate the BMI for such patients is by using this formula for adjusted weight after amputation. And composition is a very important thing we have to assess. As I told you, height and weight is not everything. So the composition is what it matters. How much is your muscle? How much is your fat? How much is your fluid? So this is the normal values. It can vary when there is a disease condition is there, when different age group, especially elders, the protein mass will reduce. In yesterday's seminar, you saw the elders, geriatric, they reduce the muscle mass as you age on. So we have to look into the body composition, and so we have various tools to assess the body composition. So the one is indirect and direct. So indirect method is through calipers and all. So we have kept the calipers in the table down. So if you want to learn how to use the calipers and the hand grip, you can just see. We'll help you. We'll show you in the break time. We can come. Okay, so these are the skin fold measurements which we use. So mid-arm circumference, first of all, we have to measure the distance between the acromion and olecranon, note the midpoint. And then midpoint, we have to sling the measuring tape around to find the mid-arm circumference. So in that area, we have to, in the tricep area, we have to clip the fat to find the tricep skin fold. So these are the bicep skin fold, suprailiac and subscapular. So these are different areas where the skin fold measurements are measured. And mid-arm muscle circumference. Okay, mid-arm circumference, it is inclusive of the fat and the muscle. Okay, to find the mid-arm muscle circumference, you have to minus the tricep skin fold. Okay, so this is the formula. Mid-arm muscle circumference is equal to mid-arm circumference minus tricep skin fold into 3.14. So you'll be able to find the muscle circumference. So these are the normal values for all the mid-arm circumference, and we have to find out whether the patient is malnourished based on that. Okay, so we have to measure the patients and compare with the standards. And next comes the whole body density using the BIA. We can use BIA. BIA is bioimpedance analyzer. So we have that tool with us. Minute voltage is sent through the body, and based on the resistance, we will be able to assess how much fat, how much water, muscles are there. Okay, so this you see that down there's a body composition assessment tool, BIA. Okay, so this is the tool. So we have to have electrodes which will be clipped in the hands and the feet, and we have to enter the patient's height and weight, age. So all this has to be fed into that BCM, and then it will give you reports on the body composition. Okay. This is a DEXA scan. It's very costly actually. It will give also the more information on the bone density, especially when patients are osteoporosis are all there. So to assess the bone density, they do this DEXA scan. Okay, so other one is this ultrasound, and the CT scans are now coming up. We'll be able to assess the patient. Okay. So this is calculating the dry weight. Okay, so based on the patient's serum sodium, we will be able to assess the patient's dry weight. Okay, so a very simple calculation based on the serum sodium. Okay, so how to do is, see, normal total body water is calculated like you, as I told you, 60% of the body water is for men, and 50% of the body weight is for women is water. So, for example, a woman's weight is around 60 kg. So, how much percentage is the water? 50%. So, how much it is? How much kg? How much liter of water is there in the body? Patient weight is 50 kg. So, 50% is water means how much? 25. Correct. So, after that, second step is actual body water based on the serum sodium. See, a normal serum sodium into the liter of normal body water divided by actual serum sodium will tell you the actual body water, and the excess body weight is actual body water minus the normal body water will give you the excess body water, and this has to be minus from the actual body weight. So this is just an example. So normal body water is equal to 60 kg into 60 divided by 100 gives 36 liters. So this is first step. Okay, and second step, actual total body water is equal to 142. 142 is a normal serum sodium into 36. The first step we get 36. 36 divided by 130. The 130 is the actual serum sodium. That will be the denominator. You will get the actual total body water. Then you have to minus 36. The 39 minus 36, you get 3 kg. So 3 kgs extra, that is excess body water. So we have to minus that 3 kg from the actual body weight, you will get the dry body weight. So this is how we calculate the dry weight. So this is specifically for patients who are overhydrated. Okay, and this is used the Mendel's calculation of calculating the dry weight. So patients edema, ascites are all there. So we have to minus that kg from their actual body weight to get the dry weight. This is a quick method. Then functional assessment through the hand grip strength. Okay, and even by the way the patient is walking, how many steps the patient is able to walk. Okay, so all the gait measurements is also very important tool to assess the nutrition status of the patient. Okay, so this blood test, I'm not going to it. So you should know all the different clinical things, what it indicates, what is a renal function test. So all this we have to look, and based on that modify the diet. Okay, so these are all the normal values. So when it varies, then we should be able to interpret and give the diet accordingly. So this is the serum albumin. These are all negative acute phase proteins. So negative acute phase proteins is when there is a acute phase, there is a critically ill patients, all this serum albumin all will drop. This is all negative acute phase proteins. So it indicates mostly on the inflammations. Okay, so so these are all the different values which we have to look into. And then comes the immunocompetence can be measured based on the total lymphatic count. That is percentage of lymphocyte into WBC divided by 100 will give you the total lymphatic count. So, and we have to compare with the standards. So these are the clinical findings which I already told you. So look into all these clinical symptoms, signs. Okay, so even the hands, we should ask them to show. All this will indicate nutrition deficiency. So you should know, be very thorough with that. Okay, so one important thing is when clinical assessment also includes, we have to observe the elimination, normal elimination, patient eats well, sleeps well. So all this also have an effect on the nutrition status. Okay, so fluid intake output should be looked into, especially when you're planning an enteral and parental nutrition. You have to see that patients are not overhydrated. So to calculate how much fluid you can give to a particular patient, we have to assess that, look into the urine output, fluid intake chart we have to look into. We have to look into the bowel movements, aspirations, okay, drainage post surgery. So this all has an effect. Okay, look into the bed sores and the total burns area. So urine color test, frequency, all this have to be looked into in detail for the nutrition assessment. Okay, nutrition history taking is also very important. Any food allergies, any all this has to be looked into. Okay, and we have to see patient has any comorbidities. Looking into the patient doctor's notes, it's a very important thing which we have to look into. So this is a subjective global assessment which we use for adult patient. So based on the comorbidities and the gastrointestinal symptoms, food intake. So all this we have to score them and evaluate. Okay. So this I already told you. Okay. Okay. So this is the diagnosis of the patient, and we have, based on the assessment, we'll be able to interpret what is wrong with the patient, and we'll be able to provide the right nutrition care. So this is how we calculate the requirement for the patient. So not going into it. Thank you very much. Thank you.
Thank you, ma'am, for the wonderful presentation. I request Ms. Kavita, Vice Principal, Triple M College of Nursing, to honor Marina, ma'am. Thank you, ma'am. Our next event is on enteral nutrition. Who, how, and when. The speaker for the event is Ms. Preeti KN, Executive Dietitian, Triple M Hospital.
Good morning to all, and today's topic will be on enteral nutrition, and I'll be covering a few of the things because it's a huge topic. With that, what we can cover in 30 minutes, I'll be covering over that. Okay, so the synopsis of the program will be covering on enteral nutrition, indication for enteral nutrition where it is contraindicated, and what is the feeding tubes or enteral nutrition access, and then enteral nutrition feeding method, selecting an appropriate formulation, types of enteral formulas, standard enteral nutrition protocol and feeding protocol, and steps to calculate enteral nutrition. So moving on to enteral nutrition, we all know that only when the gut is functional, we can try enteral nutrition. Enteral nutrition is a form of delivering the nutrients to the gut where it will help in preventing the malnutrition. And the most important thing is it is a method of artificial feeding that uses the gastrointestinal tract. Only when our GI functions, we can try enteral nutrition. That is the most important thing we all need to know. And people with where can we apply this enteral nutrition? So indications for, and moving on to indications for enteral nutrition, it is 4 major conditions. We can say that when a patient's appetite is low, very low appetite, and they are malnourished. And second condition is critical illness, like people with respiratory distress where their swallowing difficulty is there or their intake is low over those conditions. And people with neurological disorders like dementia and psychological problems, certain people where the intake tends to be low and swallowing difficulty problems are there. Over those places, the enteral nutrition is indicated. To keep it simple, we can say malnourished patient who is unable to eat for more than 5 to 7 days, and even a well-nourished patient who is unable to eat for more than 7 to 9 days. In those cases, we can try enteral nutrition. Patient who is not able to meet their nutrient needs, we try enteral nutrition. Patient with burns, sepsis, or some, all those places where swallowing problems are there or the intake is not meeting their requirement, over those places, we try enteral nutrition. So indications of enteral nutrition I have listed over here. Few of them are malnourished patient with intake less than 5 to 7 days, normally nourished patient whose intake is less than intake is less and more than 7 to 9 days, and with patients with neurological disorders, functional or partial gut function, adaptive phase of short bowel syndrome, and following severe trauma or burns, or these are the conditions we all need to know where we can initiate enteral nutrition. And moving on to the contraindication, where we should not initiate enteral nutrition, because it is the most important thing. We all need to know that, because once you know where to initiate, where not to initiate is also an important thing. Where not to initiate is people with severe short bowel syndrome, failure of intestinal function, and people with non-operative mechanical GI obstruction, where there is anastomotic leak or gut integrity is lost, and then distal high output intestinal fistula, and people with intractable vomiting or diarrhea. Over those places, enteral nutrition is not recommended. And people with paralytic ileus, over these conditions, or severe GI bleed, the enteral nutrition is not really recommended and it is not initiated. So once we know the where to start enteral nutrition, we need to select what type of method we are going to feed, or what is the feeding route access. So to know that they are feeding route access are like two, it can be classified into 2 ways. One is short-term access and other is long-term access. It means how much period we are going to feed the patient. How long is the period depends upon that. We need to choose the method of feeding. So when I have to talk about short term, if we are going to feed the patient only for less than 6 weeks, we can choose the short term feeding method. If it is greater than 6 weeks, it is always preferable to choose long term feeding methods. In short term feeding methods, it can be through the oral routes or the nasal routes, where the names come from the starts with the initiation point and ending point. It's just like orogastric tube. The orogastric tube means the tube starts from the oral cavity and it ends in the stomach. Similar way, nasogastric means it starts from the nasal through nasal route and it ends in the stomach. And these tubes are placed inside, inserted in human system through a either by a method or where in this they check the tube placement using the X-ray. And in long-term methods, it is mostly done through a procedure or a surgical method where a hole is made. It means jejunostomy or gastrostomy. It means that a small hole or a surgical procedure through that a tube is placed in the stomach or duodenum or jejunum. That is what is indicated over in the tube feeding process. And moving, once we decide the indication, once we check on the indication where to use, and then secondly, we have known what type of feeding method we have chosen, a long term or short term, or what type of feeding access routes we have chosen, we can go to the method of feeding. The method of feeding are 4 types. One is continuous feeding method, another is cyclic method, another is intermittent method, and one more is bolus method. Continuous feeding method is a method where the enteral nutrition is fed 24 hours continuously. It is called continuous feeding method. They don't give a break for during the feeding time. Whereas when you take cyclic method, there is a break of 8 hours where the once the feeding is started, the break is given around 8 hours. It is called cyclic method. And the intermittent method is a method where the the enteral nutrition is fed for 2 hours and there is a break of 1 hour, and then again the feed can be initiated. In that way, 4 to 5 cycles can be given per day. And in bolus method, it is a short method. In these 3 methods, where it is a enteral nutrition bag is used, and the absorption advantage of these 3 methods of continuous method or cyclic method or intermittent method is that advantage is that it is well absorbed and the nutrients are absorbed and utilized by the body. Whereas in the bolus method, it is a short method, and it where within 15 to 20 minutes, the whole enteral nutrition is prepared and it is fed to the patient through a syringe. And in the bolus method, the advantage of bolus method is patient will have the mobility, but at the same time, the disadvantage of that is limitation is that nutrients are well absorbed. We do not know that. And in feeding methods, as I said you, continuous feeding methods and bolus methods. Continuous feeding methods, we either use drip method or using the infusion pump, we can serve the patient by monitoring the right amount of nutrients are delivered to the patient. So it is an easy way where infusion pump is set, and at the slower rate, like 50 ml per hour or 100 ml per hour, we can monitor that patient receives the nutrients for 24 hours, and through drip method or using the infusion pump, the patient will have a better absorption of the nutrients. And there's one more thing we need to know when we are using this enteral feeding, that is, one is closed system and other is open system. Mostly in India, we are using open system. Closed system is mostly used in abroad, but closed system is a system. Now it is being coming in India right now, but closed system is a system where the scientific formula is prepared in the laboratories and it is more sterile, and the hang time of the closed system is 24 hours. It doesn't need any bag or it doesn't need any other things. And the closed system is a sterile method of feeding where nursing time can be reduced at greater amounts. When we take open system, where the nursing time is little bit excess, where the nurses need to prepare the feed and they need to pour it in a bag where a bag is required. And once you prepare the enteral feeds, it cannot be kept for a longer time. It can be kept only for 4 to 8 hours. No, more than that, it needs to be discarded. So this is the one small limitation which is with the open system. And once we decide all these factors, we need to select a formula. How do we select a formula? How does a dietitian goes and select the formulas is based on the 6 main criteria. One is the formula needs to be nutritionally complete. And second thing is it needs to be macronutrient complexity has to be there. and the formula is to be designed based on the recommended dietary allowances, and where recommended dietary allowance holds a regulations for nutrient composition. In that composition, whether the preparation of the product is there, we need to check all those things. And then the fluid content or the fluid restriction is there for the patient, we need to check over it. And then the specialty formulations, if required, and osmolarity of the product need to be checked before delivering to the patient. So once we decide based on all the 6 factors, we choose the formulas. How do we choose the formula? Is there are types of formulas. In that, first thing, it is classified into 4 ways. One is the formulas are polymeric formulas. In polymeric formula, it is divided into 2 things. One is commercial formulas. Commercial formulas are exclusively formulas which are scientifically prepared in the laboratories, and it is available in the market. Those are formulas are more sterile. That is why in most of the hospitals, they use the commercial formulas. Blenderized formulas means blenderized formulas are nothing other than the kitchen feeds, either dal water or rice water or something prepared in the kitchen, and it is being delivered to the patient. But these kind of blenderized formulas mostly will have bacterial contamination, and it is not more sterile, and we do not know the right nutrient composition of these formulas. Whereas in scientific formulas, we can exactly note the nutrient composition of the formulas. And moving on to the second variant is the oligomeric formulas. Oligomeric formulas are nothing other than pre-digested formulas or completely digested formulas which can be easily absorbable by a person. So when I have to talk about elemental formulas are one completely digested one which is easily absorbable, and it is used for certain patients where their digestive capacity is very less. And semi-elemental formula is where proteins are break down into peptides so that it is pre-digested form. So it can be used for a patient where there is a compromised GI. And when I have to talk about the specialized formulas, in certain conditions where there is a requirement, the formulations can be different. The specialty formulas, when I have to take more diabetes, the carbohydrate composition needs to be less and the fiber composition needs to be more. In that way, the formula will be prepared and it is available in the market. So I can choose over those products. And if the patient is having renal failure, the electrolyte needs to be less. At the same time, fluid restriction will be there for the patient. So 1 ml of formula will give you 2 calories. In that way, we need to choose a formula. So it is specifically designed and available in the market. So these are the formulas which are called disease specific formulas. Based on the disease conditions, the formulations are prepared and which are available in the market. And then the last variant is the modular formulas. Modular formulas is the formulas which holds the one macronutrient as the major composition. For example, if I have to say, it will either hold protein as a whey protein as a composition, or either a medium chain triglyceride as a major macronutrient. So it holds only one macronutrient as a major form is called as modular formulas. So this is a composition, how the formulations are made or based on the what criteria and what composition of macronutrients it needs to be. For example, if I have to take a normal standard formula, it will give you 1 to 1.2 calories, and the protein will be around 15% and fat will be around 30% and carbohydrate 59%. So in this base, they would have prepared the formula, and or any company they prepare, they have to prepare based on these compositions. So this is a chart which will be helping you in how to identify formulas are right or wrong. So moving on to the next thing is the standard nutrition protocol. Whenever we plan an enteral nutrition, we need to follow some protocol or guidelines when we recommend a patient, because guidelines are more important. They help us in improving the quality of the life of the patient. At the same time, it will help in preventing the mortality rates. It reduces the mortality rates. So here the standard protocols based upon your every institution, they can choose the protocol which they want. there are many guidelines like ASPEN guidelines, SCCM guidelines, uh, and European guidelines or Canadian guidelines and Australian guidelines. There are multiple guidelines, but what is suitable for our hospital or for our institution, we can choose over those guidelines. And the standard guidelines I have taken is European Society of Parental and Enteral Nutrition Guidelines, where it states we can recommend around 20 to 25 kilocalories in the initial phase of enteral nutrition. And when in the anabolic phase, when in the recovery phase, we can use 25 to 30 calories. We need to provide them per kg body weight. And if the patient is obese, we can, as per the ASPEN guidelines, it states you recommend 11 to 14 calories per kg body weight, or either with the ideal body weight, we can use 22 to 25 kilocalories per kg body weight. So these are the standards or protocols or guidelines which will help us in betterly serving the right nutrition for the patient. So standard enteral nutrition protocol, once we know, we will decide all these factors we will take in, and then we have to feed the patient. When we feed the patient, we have to check for these things. Like first thing is that we need to elevate the bed of the patient to the 30-degree angle, and then only we need to feed the patient. And second thing is that always the feeding rates need to be started at slower rates. Start with 50 ml, and then you can reach the target of the day. Initially, when we are starting itself, we need not start with 100 ml per hour or 200 ml per hour, which will not work out. And third thing is that any formulas which once we feed the patient, we always need to flush the water every 4 to 6 hours in continuous feeding. Or when we are using bolus method, once before and after feeding the patient, we need to flush water to prevent the clogs in the tubes. That is most important. And if the gastric residual volumes are higher than 500 ml, do not stop the feed, because we always need to check the gastric residual volumes every 4 to 6 hours once for a patient. When we check the gastric residual volumes, do not stop the feed if the residual volume is more than 500 ml. We always need to reduce the feeding rate, and or we need to restart the feeding with the slower rates, and we need to progress on for the better tolerance. So how to calculate enteral nutrition needs? It is a 6-step process. First thing is that we need to estimate the patient nutrition need. Second step is select the tube feeding formula. Third step is select the method of feeding. Fourth step is determine the volume of feeding to meet the estimated calorie and protein needs. Fifth step is documentation, where we need to document the things once we do all those things. And the sixth step is reevaluate the regular feeding or monitor the regular feeding process. So the steps wise, if I have to tell, estimate the patient nutritional need is, first we need to assess the patient based on their nutritional status, whether they are well nourished or malnourished or severely malnourished or mild malnutrition. Based on that, we need to decide the calories and we need to recommend them the calories. And second thing, once you decide the calories based upon the patient's nutritional status, you need to move on to the selecting the tube feeding formulas. What type of tube feeding formulas? How long is the patient going to be fed? And what is the formula we need to feed for the patient? All these factors need to be decided in the step 2. And in step 3, what way of we are going to feed the patient? Whether it is the method of feeding is continuous feeding method or bolus feeding method or intermittent feeding method or nocturnal feeding, or what type of feeding it is going to be, we need to decide. And then how many cycles we are going to feed the patient, and so that how the patient is going to meet the nutrients have to be decided in the step 3. And fourth step is that based upon the fluid restriction or based upon the volume we decide, we need to feed the patient either through continuous feeding methods or bolus feeding methods. And the fifth step is documentation, where in fourth step we need a little bit of mathematical skill to calculate based upon the requirement. We need to formulate them. And in fifth step, it is a documentation. Once you make everything, you need to prepare a chart, and where the based upon the patient nutrient needs, enteral nutrition chart is prepared, and it is need to be given over, instructions need to be handed over to the nursing team, where they can take care over from that process. And final step is where we need to monitor the enteral feeding, where the prescribed amount is being received by the patient, whether they have received the 4 cycles what we have prescribed or not. It is the final step. Once we monitor only, we will know whether they have better tolerance or if they don't have the tolerance towards the enteral nutrition. So it is a simple where bolus feeding method calculation. It is for a just for a simple thing we have given over here 7 steps which we have which I have used is: first step is estimating the nutrition need of the patient. Second step is selecting an appropriate tube feeding formula. And third step is determining how much the formulation is required. And fourth step is divide the amount of formula by the number of the feeding sessions. And fifth step is calculating energy versus protein and fluid requirement, where a simple mathematical calculation involves over there. And sixth step is establishing how much of free water is required before and after the flushes. And seventh step is decide whether it is a bolus regimen or intermittent regimen. These are the 7 steps which we need to do it even for and bolus feeding or continuous feeding method, and we need to feed the patient. So this is based on this, I have given a simple calculations. In the first step, we have taken a body weight of 60 and we can prescribe around 25 to 30 calories. Here I have given 30 calories and I calculated 1800 calories. In step 2, where I have made a selected a formula, what type of formula is required for the patient, whether disease specific or standard formulas, we need to choose on that. And the third step is determining how much is the formulation required. That is, I have given the total calorie requirement for the day divided into the amount of calories for the 100 grams of the powder, so that it will give how much of the grams of nutrient powder is required for the whole day. And fourth step is how many feeding sessions are required. So 8 feeding sessions through bolus method means I have given how many feeding sessions are required and what time we need to feed the patient. I have given over here. And fifth step, I have calculated how much is the protein and calorie which comes over through the calculation. And sixth step is establishing the free water flushes. How much of ml of water we need to give as a free water before and after feeding. I have used here 30 ml. That is what is the calculation over here. Thank you.
Thank you, ma'am, for the detailed presentation. I request Marina, ma'am, to honor Preeti. Now we have a 10-minute tea break. I request you all to be back. So the tea is arranged on the right side. Please be back in 10 minutes. Those interested can come forward to look at the devices placed here.
experience you shared at bedside. So I request everybody to be enthusiastic and just giving your contribution onto this topic too. Okay, we'll start with enteral feeding. So enteral nutrition, it is the macro and the micronutrients an individual have to maintain an effective living for their lifespan. Whether it is possible, it's a question to all of us, whether it is possible if a patient who's having a neurological problem or with any complications with any associated diseases, when they are not able to have a normal meal like us, how they're going to take up, how they're going to meet this micro and macronutrients, whether it's important for a person to take all this, consider this when they are in pain and alleviation, whether they'll be able to concentrate in their nutritional status. So for this, to think about all this, we are here under this room, just to put all your brain, mind together, soul together, to gain some knowledge so that when we go to the bedside, think how we have to contribute our knowledge or the whatever inputs you're getting for these 2 days, how well we are going to spend on patient bedside. Think about all the patients. Now, just I'm through putting all you in ICU. Go into an ICU setting where the patients are confined to bed. They are not able to move themselves. They are already having too many complications from head to foot. If you see, there are too many investigation, physical assessment, which you do manually, mechanically, and also with electronic devices as we are doing before starting my class. So all this assessment plays a vital role. So first you do all that, then get on to the bedside. See your patient, how he or she is. What is your role? How you're going to conclude? Whether the patient has to go on a oral nutrition, enteral nutrition, parenteral nutrition, or etc., etc. How you're going to feed the patient, right? God states that have your food, be well nourished, delight yourself, be blessed with the food. So whether that blessedness and that is going to be with the patient is the question we need to, we are all as a team going to help the people who they cannot take care of themselves. So enteral feeding is a method which supplies nutrients to the stomach directly or indirectly. So it goes to the gastrointestinal tract. So from there, there are various indications which are the patients you need to go with enteral. So as I started as assessment states there. So assess yourself whether my patient can take her own, whether she can take herself the feed, whether it will be digested, whether she's having vomiting, nausea, whether she's comfortable. All that you assess first and then think about it. It is you who have to discuss with your dietitians and the doctors, and it is a team effort where you need to decide whether the patient is going to be the enteral or parenteral or oral. So unable to consume adequate nutrition, you can take them into criteria. Swallowing and sucking reflex is not possible when a newborn is there. Facial and esophageal structural abnormalities, anorexia, eating disorder, they're not able to eat, increased nutritional requirements where they are not meeting their needs of nutrition, and congenital anomaly where they're not able to take at all. So along with all this, all disease conditions I put over, so even that is an additional indication where you need to keep as one indicator. So for all of them, you start your role with feeding routes. So which is the route? How I need to go about, how to decide on. Most commonly used place is feed into the patient's stomach. It has to reach the stomach. That's it. How you're going to give, whether it's a nasogastric or oral route you're going to give. Think of that. Necessarily, possibly feed directly into the duodenum or jejunum. That is again which will go through the skin. So you can even put a tubes there and you can directly feed if they have some problem with their stomach. So decide whether it is a stomach or duodenum or jejunum. So enteral can be given in all different routes, which I will give with a picture. You will get a brief idea. So enteral nutrition will give through any tubes, which will just inserted through nasogastric or jejunum. And it is a feed which reaches the stomach. There digestion takes place. Patient gets the macro and micronutrients for their living, and they have a good nourished environment, healthy human when they are at the bedside. We always focus on all the disease condition and other parameters. Whenever we think about the nutritional, we never think about whether they have had adequate water, food, any fruits, all that. As nurse is seated here, I would like to impose that please make sure your patient's nutritional status is very important for any sort of disease condition. If they are not well nourished, if they're not taking adequate water, whatever treatment you're going to give, it's waste. So make sure it is your role, which is contributing with the dietetics. Take the feedback from them and go ahead with the feeding schedule. Make sure your patient is having adequate nutrition and water for their well-being. For the treatment also, they have to cooperate too. So this is one type of nasoenteric feeding. Here you can see nasogastric feeding tubes and also neojejunal feeding tube. So a tube is put over through the nostrils and it reaches to the stomach. You can see two different colors I have shown. This is one method where the tubes are put into the patient body. So whenever you are inserting, we are taught that you have to check with the how you will insert. Make sure patient is following when you leave the tubes in place. All that mechanical methods how it's been taught to you when you are studying, but still make sure with knowledge, with courage, and with power, whatever you're going to do, with self-confidence you do. If you have little bit of doubt also, you may damage the tissue of the layer. So make sure you comfortably insert the tube inside the patient's stomach and there is no bleeding assist or anything. So make sure the tube is placed proper and assess the tube before inserting, the size, the nostril size, how it has to be measured, the tip of the nose to tip of the earlobe and to the xiphisternum, and then insert the tube. Make sure it is there inside the right place. That is the important note what you need to take when you are inserting the tube. This has to be done twice before inserting and after start of the feed and completion of the feed. You need to check whether the tubes are in place. There are different methods to check that. I don't want to waste on my time. You know, you will take a bowl of water, all that procedures. Along with that, now the advancement is that CE markers can be used to check the pH value. Make sure it is more than 5.5, which indicates the gastric positioning. And if it is pH is 6 to 8, it indicates the presence of small bowel, it is there. So these are the indicators which make comfortable for you that your procedure is right. Then go ahead with starting with your feed. This slide repeatedly will be coming in my presentation. So with 3 colors I have given: bolus, intermittent, and continuous feed. Whichever you're going to give the feed, make sure these points are just hammering in your mind. So I have very easily put it here. 15 to 20 minutes period of time you need to give. 150 to 200 ml you need to give at each feed. If it is an intermittent, make sure the volume is 30 to 60 minutes. It is being given in several times of a day. And if it is continuous, it is 8 to 24 hours often. An enteral feeding pump set to be prescribed according to the rate what the dietitian tells and to your intensivist or the doctor, whomever is going to take care of the patient. So make sure this you will keep as a protocol when you are starting the feed for a patient with any method of feeding. So this will be a repeated slide in each methods of feeding. Shall I move the slide? This is the other method, gastrostomy. Typically, the enterostomy tubes are used when enteral feeding is expected. This is for lasted long period. So when I told about the assessment, make sure you think about how long the patient is going to be on a tube feed, whether it's for a week time or a month time or continuous feed. So based on that also you need to decide. So this is for the longest stay. You think they are very badly nourished, they are emaciated, they need support of nutrition, they cannot take, they are not digesting proper, there is some problem in the gastroenteric tract, you need to go for this gastrostomy. So this is sometimes referred as percutaneous endoscopic gastrostomy. When you're not able to do, you can go with your endoscopy or PG, or with a gastrostomic button, you can just go with the gastrostomy. So this is the picture. You can see directly it is going to the stomach through the skin layer. So there the gastrostomic tube will be placed. You need to administer whatever you did for previous method, the same way it will go with us. So again, I told it's a repeat slide. Make sure same principle, 15 to 20 minutes and 150 to 200 ml. Intermittent means it is 30 to 60 minutes and continuous it is 8 to 24 hours. So make sure the same method will be followed. Other indication steps and all I will show in further coming slides. So this is jejunostomy, third method, where you see Feeding is expected lasted longer than that, more than 8 weeks when a patient is in a suitable condition for insertion of the tube. So this is sometimes referred as PEJ, that is percutaneous endoscopic jejunostomy. So PEJ is very uncommon, but still we are using. Mostly we don't see in our hospital. We just go with nasogastric tubing only. So make sure if even more the condition is worse and the patient is going for even more longer days, you have to go with jejunostomy. This is a picture where you can see there is a port also fixed. G-tube ends here. Here you need to maintain a proper preparation. Preparation is very important in jejunostomy. So because it's going directly into this small intestine. Again, the same methods it's been displayed here. So I'm just moving the slide. This is gastrostomy with jejunal adapter. So with an adapter you can go. This is the fourth method. This is to avoid second surgical procedure. Patient is almost sick. Again with the surgery, if he is not going to be tolerated, go with an adapter technique where performing a jejunostomy through a replacement of existing gastrostomy. So you have your gastrostomy, along with that you put an adapter and joining with the jejunal adapter. So this is another thing. So I have coded in red because it's an essential tube which enters the stomach through the abdomen wall, and it is held fixation device with the adapter. That is what the terminology, the jejunal adapter is there. So this can sometimes be referred as PEG-J, to have a differentiation with PEJ and J. So for the above following things, there are 4 methods I have discussed. Now we will just go with the indicators of adequate fluid resuscitation in a critically ill patients. So when their patients are very critical, you start with your assessment. Make sure the other parameters also you are making a note of. The height of the patient, weight of the patient, what is the urine output, whether it is more than 30 ml or less than 30 ml. Make a note of it. What is the heart rate of the patient, systolic pressure. So all these vital parameters is very important when you're taking a nutritional assessment with the patient. So it is done in 2 ways by our dietetics department, nutritional assessment with screening the chart. So when you are doing as a nurses, just put 2 minutes to just go and correlate with the dietetics notes, what they have prescribed there, what they have written. So make sure your chart, the nursing chart, will go ahead with the intensivist and along with the dietetics, so that you will get even more a brief idea how you have to go with the feeding techniques. Otherwise, just blindly you will be pouring into the tubes. Patient will end up with diarrhea or any other complications, infection. There are so many complications associated with that. So just do not play with the life. Make sure you correlate with a team of people, put forth everything together, mind, soul, and then go with this. So make sure urine output is, if it is below 30, or your heart rate is more than 120 or systolic or approximately 100, and then ask with your medical team, go ahead with the feeding technique. So start there with the nursing care. You have to take the physician order, start, and you discontinue the feeding for solution type, volume, flow rate, and blood works as appropriate. So check the blood appropriates also in order to continue your feed. So make sure you correlate with dietetics also, and then go ahead with the plan of nursing care. Third, you go with the specific consideration. So what I need to consider, always when a patient is on a tube, make sure he is in supine position with 30 to 40 degree tilt. Otherwise, they will put themselves into aspiration. They may die also. So always when there is a tube is there, when you're there at the bedside, make sure your patient is in sitting upright position. If it is flat, have a red alert there. You are in a red alert, patient can go into dyspnea, means in aspiration, and they may die too. So make sure 30 to 40 degree, 45 degree head up position is there in order to prevent all unnecessary complication. Second, feed for 30 minutes in 1 hour prior to placing the patient in supine position. So just like that, hastily you don't do. Make sure you give some time span and then you start up. Monitor patient intolerance for tube feeding. Little bit you give, assess the patient condition. Flushing have to be done, assess whether they're tolerating. If they have cough, they're not able to tolerate. Before that, check whether the tubes are in place. There itself, you'll get an idea. Even though the tubes are in place, patient is not cooperating, stop a while, Think about other contributing factors which I have discussed in the previous slide, and then go ahead with the feeding technique. So monitor the patient blood workups. Along with that, room temperature for the infant. Don't get hot milk and all. Don't just pour like that. Bring it to the warm or a room temperature, and then you can feed. 6th point will be the feed on recommended with jejunum or in the duodenal tubes. And do not put a stop clock with the tube feed tubing. If you're going to give any medication, do not give sublingual, and make sure the entry-coated or sustained release medication do not give with the feeding tubes. So when you give with the mortal and pester, just crush the tablet proper. If it is a coated tablet, do not do that. And then you have to mix well. Make sure it is well mixed with the solution, and then you administer to the patient. So confirm correct placement of tube. This is again repeatedly I'm telling, in order to prevent the complication. Assess tolerance of tube feed, whether there is abdominal distension, nausea, vomiting, diarrhea. All this you need to keep always in your mind when you're starting with your feed. Check whether patient is comfortable, and then you do. So for this, what you need to do, how you will find whether the patient is having abdominal distension? Anyone? What is another important point we need to do in our assessment related to abdomen? Yes? Abdominal girth. So if you find the abdominal girth, you will be able to correlate how it was before you start up your procedure, now how it is. So make sure abdominal girth is also monitored. Flush feeding tubes. Frequently, the tubes have to be flushed every 4th hourly for continuous feed. So make sure you flush the tube. When we come for rounds, we see always precipitate present onto the tubes. That is not encouraged. That will put up in indigestion problem, diarrhea, and also infection problem will be there. So make sure your tubes are clear. It has to be flushed frequently. At least make sure every 4th hour you are just flushing the tubes in order to prevent unnecessary precipitate present onto the tube. Before and after each tubes, you need to flush for intermittent. Before and after each medication you are supposed to do. Amount of flush. Make sure 20 to 30 ml sterile water is given, not the tap water. Do not use tap water. Do not use ordinary water. Make sure if they are going to do at home, tell them to boil the water to 100 centigrade and then cool the water and then use that water. So that all you have to keep it in mind when you're giving discharge advice. So that is how. So make sure you're giving sterile water. For pediatric, it is 5 to 20 ml, and for adult, it is 20 to 30 ml, and for neonates, it is 0.5 ml distilled water you will give. Flush with push pass technique. Same like syringe, how do you do for bloodstream infection prevention? Same way, push pass technique, so that anything there, it will be washed out continuously. Make sure push, pass for some time, again push, pass for some time. You can even rotate and do, so that all over the tubes is flushed out proper. This is flush technique which you need to imply for all the tubes. Insertion site also have to be monitored frequently. Follow post-insertion order. Observe and assess the insertion site, the skin condition, any oozing is there, redness is there, drainage is there, leaking is there. All that you need to check onto the tube inserted site. Clean the insertion site every 12th hourly. At least 12th hourly. I will again repeat, at least 12th hourly. Do not leave just doing any clean procedure. Apply gauze dressing if required. If there is a ooze, make sure in a twisted motion you clean the tube. There should not be any sticky thing present onto the insertion site. That becomes as a biofilm, again, which enforces on infection control. So make sure it is clean enough to secure the tubes. Check security of your peg and the supporting things whichever is present in order to prevent the dislogging of tubes. For NG, OG and ND tubes, observe the skin nares or the lips. It should not be dry. Make sure you keep something moist over the lip or to the nostrils. Clean it proper. Alternate nails can be used so that they are comfortable. Frequently, you can inform them how long they're going to have. So make sure alternate nails with reinserted NG tubes, if possible needed, you can go ahead. That with the advice of your intensivist or your doctor, who am going to be advising on NG tubes. So coming with the administering the enteral feeds. So here I want your contribution. I'm keep on talking. So just let me know how we are doing at bedside of MMM, how we start with enteral feeding, whether we have a format for it. How many of you have seen any format for enteral feeding? No answer, all sleeping? Yes? Anybody observed any charts we are using for assessment of enteral feeding? Yes. Yes. How many of you have seen? What are the parameters there in that enteral feeding format? Even staffs can answer, I think. Why I'm asking this is that forms are there not to just for namesake. You all see a form, just closing your eye, you write whatever parameters you have already put in your mind. I don't want that practice to happen. Make sure for each patient it is different. So make sure for each patient what is the exact parameter, check on to the patient and write that, so that the current record is maintained there. It is a note which is giving an idea about the improvement of a patient condition. Just for namesake, do not do any form writing. It is not just for NABS sake we are having forms. It is for continuous of treatment, which will be helping the doctors to even more work on to the patient condition. It is for giving an idea for a dietetics people to just go on with additional nutritional support. It is for so many other contributing things. So make sure each form is having its value. Do not just like that fill the form. Clear? So make sure the equipments are there set right to the bedside of the patient when you're starting the administration of your feeds. The 50 ml syringe, alcohol wipes. I'm just given an important note alone. Other things, whichever you want to have for your practice, you can go with that. So alcohol wipes, sterile water, universal funnel adapters, glove, apron, and then clean jug. And make sure your hands are clean and free of pathogen. A normal flora of a skin is Staphylococcus aureus. We never think about that. We have 101 bacteria in our hands. We just go to the bedside. We touch all over all lines. Please think wise before you touch the patient. Each patient has got their own pathogen. Each line has got its own pathogen. So do not touch each tube and then casually handle the tubes. Make sure you would sanitize your hand before touching any tubes and then go ahead with your procedure. Prevent MRSA to the patient. It's a simple procedure, even though it is a simple thing. If you're going to each shift, each nurse going and touching a patient, you are putting the number of count of Staphylococcus aureus on the patient, and patient will be leaving the hospital with MRSA, which is called as nosocomial infection. So don't do that. Clean your hands. All your articles to be clean enough. For sterile things which have to be sterile, make sure the sterile articles are there. So wash hands, put on to the glove and the plastic apron. Flush feeding with 30 to 50 ml of sterile water, and then feed the peg and clip the peg is then reclosed. So make sure you're closing the clamp before ending your procedure. Check expiry date and use the products whatever using. Just blindly do not mix with the water and pour onto the patient. Always take the box, read the box, what is the product, whether that product only advised by the dietetics department, how much they have given, what ml it has to be prepared. We are getting a prepared solution, that's okay. If not, make sure when you're preparing, you're checking for all that expiry date and then you prepare the solution. Then uncap the tube, connect the funnel adapter. Then you have to go with your syringe technique, flush, and then start with your fluid. So for gravity, you can do all the techniques whichever been taught, raising your hands and starting with your feed. So prior to that, make sure the syringe is emptied, top up with the feed until all has been given. And closing with that, go with your flush technique in order to prevent again any precipitate onto the tubes. So make sure you flush the tube with 30 ml. That is also again and again, I'm repeating, we are in cardiothoracic hospital. Some patients will be going with the limited fluid. If it is 1500 ml, make sure accordingly you are administering. Here we have told that 50 ml, 100 ml, 20 ml, blindly don't go and do. Check with your patient what is the advice for your patient. Based on that, calculate the total amount of fluid and then give. Clear? Then wash the adapter, store, clean syringe, wash your hands and leave the area. So store unused feed in a refrigerator. I will advise no. If at all, if it is there, you can, not a problem. It can be stored only for 24 hours, not more than that. But make sure, again, it is not spoiled or there is no bacterial growth chance for the solution, whatever you're going to preserve in the fridge. My advice will be not to do so. Fresh feeds will be advisable. Record the amount of feed given in the flesh. Ensure the patient is comfortable. Observe whether the patient is not tolerating the feed. There is no vomiting, nausea, distension of abdomen, any problem after your feed. See, assessment, reassessment have to be followed. Make sure all that's continuously being done. Maintain patient position upright for 30 degrees. Till then they are comfortable, and then you can assess them. Do not place the patient flat. Make sure they are always in sitting up position. Do not put anything down the tube that is not recommended by the dietitian. So make sure you are sitting for 2 days. You would have got wide view. What are the products available for meeting the protein, calorie, and the minerals? So go according to the dietetics comment and then go over the procedure. So documentation, record whatever you have done. What are the symptoms you have assessed on to the patient? Signs and symptoms. What are the signs and the symptoms patient can communicate? Take down that too. Document everything, and then feeding system change and appropriate record have to be done. So make sure documentation reads the mind of your work. So make sure your work is done in a proper way. That is carried out only by documentation. I have done the procedure, I have checked everything, but not documentation is not done. That shows that you have done some failure procedure. So make sure your procedure ends with documentation. So infection prevention and control is very essential. Repeatedly, I'm telling, because we cannot add on to another complication for the patient. So diarrhea is the key problem. What patient can have, albuminuria or oliguria, anything can be there. So make sure you are not putting your patient into serious infection by encouraging giving enteral feeding. So it is in your hands. Put your mind, brain, everything together and prevent infection. So rinse the tube. Do not have any precipitate on the tubes. Cover, label the refrigerator. If at all you're going to store anything for 24 hours, wash your hands, mindfulness to be there. Not only you who have to assess the patient, even that person, and round the clock, 24/7, infection control will be everybody's business. So make sure all are following it. Solution will be suspended for no longer for more than 4 hours. So make a note of this. More than 4 hours, do not use that. Avoid adding a new formula to the patient without informing your dietetics department or with your doctors. Make sure you're getting a clue from them and then start with, because it can also add a complication to the patient when you're adding on a new product. So it might be a neonatal or a pediatric or an adult. Make sure you do a study and then you go with the product change. So change the administration set every 24 hours. Make a note of this. This is an NABH standard. So make sure the Riles tube or a tube you are given for NICU also, it has to be changed for 4 hours for neonatal, and for adult it is 24 hours. Use a sterile water flush, no tap water. So every 4 to 6 hours during the daytime, before and after the feeding, you are supposed to flush. Before and after drug administration, single patient use systems to be used and discard within 24 hours. Feed and feed reservoirs to be given as a set must not be reused. Make sure one patient, one tube, same like one syringe, one patient, one needle. Same way, one patient, one tube, and discard that within 24 hours. Ready to hang system can hang for 24 hours that do not have an adapter or opening in that thing. Make sure it is closed, sealed proper. There is no approach of any point of infection in that point. Feed the reservoir and not be lower below the level, giving to avoid the reflex. So again, it is continuing. Opened containers of feed should always be kept in the refrigerator and to be used within appropriate time frame. So what time frame I have given for refrigerator? Exactly. Okay, so decanting into separate containers should be avoided. Make sure you don't give any tinned products like any fruit juice which is there in the pockets or in a cane bottles. That is not advisable because that will put into infection. So for that reason, we are telling, in order to prevent contamination, do not go for all that. If any gastric tube is pulled out, accidentally, it should be displaced. It is displaced, it should be removed, and then only you have to insert. Do not try to hastily insert again. So here I stop. So do you think that enteral feeding is safe? Yes, it is safe when you have a safe practice. Otherwise, it's a question. Yes, it is tolerated by most the patient. So you can go with enteral feeding. It's not a problem, but think about the complication before you start with any procedure. So don't put yourself into problem or your patients in trouble. So complications always have to speak in your mind. If you're not going to do all the procedures or protocols which have been set forth by the American Association of Nutritional, or with the protocols which is set forth in your hospital, the patient is put in complication. It might be gastrointestinal disturbance. Most probably it might be any problem related to diarrhea, or followed by any mechanical or metabolic complication associated with patient living. So make sure we avoid all that. It is our business as nurses and dietitians and as doctors. We have to put our mind everything together, prevent many problems associated with the enteral feeding, and keep the patient comfortable when they are under our monitoring. So make sure you prevent them from all complications, keep them healthy, prevent them from all nutritional problem, and keep them safe. This will be my take home message. So all 5 points I have given, it's just a quick brush up. So all patients receiving the feeds to be always follow the protocol, make sure the protocols in place, confirm the placement of tube before and after the enteral feeding, prevent and managing the obstruction of tubes, handle with care with the formula procedures, administer the formula procedure. Any protein products, read about the protein products, how much calorie it has got, how many protein, what is the fat value it is there in that, whether it is comfortable with the patient. You would have seen so many parameters which has to be enforced. Think about the blood parameters. Comparatively, you have to do blindly. Please do not go with any products if they have got any additional problem that will be having with a metabolic disorder. So make sure all that is set forth, and then start with your enteral feeding. Fine bore tubes easily misplaced or dislodged, so be careful. Correct positioning of them is very essential. Multiple factors like diarrhea or in tube fed patients is noticed, so make sure there is no complication associated with malnutrition or hypoalbuminemia or any other lacto intolerance problems. Think of all this. Even for neonates, if neonates are having some lactose intolerance, do not give blindly. So check with the parents, and then you have to start with the enteral feeding. Do not contaminate repeatedly. I'm telling, bacterial contamination is, that's it. You are killing the patient. Already they is emaciated with all, there is no nutrients in their body, minerals not there. So again, with you are adding on complication, they will put to death only. So be careful while starting the feed. Urine sugar and acetone level have to be checked every 6th hourly. So when you are doing your assessment, make sure your checking of your sugar and acetone is also important. Along with that, make sure the serum electrolyte is in place, blood urea, nitrogen, and also glucose level is there in place. So think all this put together in a chart where already the dietetics department has given. So enter all this in the chart, follow up what are the feedings you have given, how frequently your flesh, whether tubes are clear, all reassessment and assessment to be done, and then you conclude your procedure. So ongoing nutrition assessment are necessary to provide information about the overall adequacy of enteral feeding, restoring and maintaining the nutritional. So it is in our hands. We have to set forth everything together, make sure the rules and regulations, the protocols in place, along with your intensivist dietetics and the consultant, go with the treatment. It is very important. They all depend on your protocols and your assessment. So your weight reading, your BMI, your whatever readings you are taking, that should be correct. If you are recorded in a wrong way with the wrong patient, that becomes a problem. So keep in mind all safety rules in mind, and then go accordingly. Otherwise, it is all going to put the patient in trouble. So I think we all have learned what is enteral feeding. We will be giving a safe life to the patient. Stay blessed and be a blessing. Thank you. Anything to be added or any doubts, you can just let me know. Commonly, you can have a calorie intake for a patient with 25 to 35 kilocalories per patient per body weight. So that you can keep as a basic, so that you can start with your feeding for the patient. So here I end. No questions? It was too boring? I'm sorry, I need to do no other go. It's a very important procedure. Make sure you don't give unnecessary complications or any other problems to the patient. Just don't think it's a simple procedure. When we learned it's as a basic procedure in first year, we always have that. It's all basic procedure. We can just do as we like. It's not so. It is actually comparatively with advanced nursing. So go with carefulness how you need to take everything in place. So make sure you have all principles in place and stand forth for your patient life. Thank you.
Thank you, ma'am, for the wonderful presentation. I request Ms. Rachel, Senior Manager, Front Office, to honor Ms. Ranjita Manderson. Thank you, ma'am. Our next speaker is Ms. Arogya Jaideepa M., Deputy Chief Nursing Officer, M. Her presentation is on how to handle parenteral nutrition. She is a registered nurse with a master's in nursing with specialty of obstetrics and gynecology. With 16 years of experience, she's a life member of TNAI and a recipient of several awards, including Best Scientific Paper Presentation, Best Ambassador Nurse Award 2019, Best Research Paper 2019, and Best Teacher Award. Ma'am, we are very happy to have you here.
So very good morning, one and all gathered here. The continuation of the last speaker, I'm going to take about the parental nutrition. Anybody can explain what is the difference between enteral feeding and parental feeding? Both are same. Okay, thank you. Okay. When the patient couldn't able to take the food by or the patients on the NPO, we have to meet the nutritional need of the patient. That time we are taking the line through the peripheral line or the central line. You're giving some nutrition substance to the patient, save the patient life is called as a parental nutrition. The definition is stating like that. The total parental nutrition is a method of feeding that bypass the gastrointestinal tract. Fluid are given to the vein, provide most of the nutrients the body needs. The method is used when a person cannot or should not receive the feeding or fluid by the mouth. And one more definition. Parental nutrition is the feeding of the person intravenously, bypassing the word is very, very important, bypassing the usual process of eating and digestion. When we would like to give like a supplementary of mineral, amino acid and lipids, we can give through that line and save the patient life. So what is the major aim? We have to give the proper nutrition to the patients to prevent malnutrition. This is the main aim of the parental nutrition. So already we discussed what is the difference between enteral nutrition and the parental nutrition. When we are giving the food through the nose or the gastrojejunostomy or the jejunostomy directly to the stomach to save the patient's life. In case we couldn't able to do the thing, we are giving through the peripheral line is called as a parental nutrition. So what is the major indication? Is broadly is classified into three. One is that when the person is having the severe burns, that time the fluid lots will be more. So we have to calculate and based on the patient's needs of the electrolytes and minerals, we are giving the feeding to the patients. The second thing is the GI disorder. The next slide I'll explain what are the conditions we have to give for the parenteral nutrition to the patient. The third important thing, the patient, those who are with the acute immune deficiency syndrome. So now we are going to focus on the person those are having the malfunction of the GI tract. That patient is need for the parenteral nutrition. What are the condition is coming under here means first when we would like to give the bowel rest to the patients, the condition like small bowel obstruction, ulcerative colitis and pancreatitis. That time we should not allow the patient to more work on the digestive system. So we would like to save the patient's life. That time we are giving for the parenteral nutrition. The second one is already we discussed when the patients on NPO or the patients are couldn't able to have the food on the time and 7 days more than the NPO or the patient those are going for the major surgery with the more NPO days, that time we can select it for the parental nutrition. The next one is that pediatric cases, especially for the newborn congenital anomalies with the GA tract, that time also we can go for the parental nutrition. The last one is that extreme malnutrition patient also we can advise for the parental nutrition. So the routes of administration, coming to the routes of administration, we discussed, we can give through the any one of the vein, through it mixing with the bloodstream, directly entering to the jugular vein or the subclavian vein through the SVC and entering to the heart, it is giving the supply to the patients. Okay. So in the cases, we have to broadly, we are classified into two areas. The routes are broadly classified into two. One is the peripheral line, one is the central line. First one, peripheral line, the superficial vein. When you are giving for the low osmolar nutrient, like single portion of lipid or the amino acid you like to give to the patients, you can go for the peripheral line. In case if you would like to give for the higher end, 3-chamber packs, like lipid, dextrose and amino acid, you can select for the central line. Then coming to the central line, again it is classified into two. One is the central line insertion, one is the PICC line. Peripherally inserted central line catheter. Generally, we are cannulating in a brachial line or the cephalic vein. Okay, most of the areas they will select for the PICC line for the TPN infusion. So, as we are the team members, we should know when we have to select the central line, when we have to the peripheral line. So it's broadly classified into two areas. First is selections of the vein. When you like to give for the high osmolar, we have to go for the central line. Central line, you can go for the jugular line or the subclavian vein. When the two vein we couldn't be able to take it, you can go for the last option for the femoral vein also. Next is that when you like to give the more time for the TPN to the patients, you can go for the central line approach. Next is the high osmolar, already we discussed. Then full requirement. The patients will fully depend on the central TPN fluid, you can go for the central line approach. Next is would like to infuse the more volume to the patient, you can go for the central line. Then major problem with this infusion, the patient is going for the infection. In case if you are cannulating in the central line, the patient is going for the CLABSI, central line associated bloodstream infection. If you are going for the IV line, the patient is developing the phlebitis. Next slide, we are going to discuss about that. What are the type of enteral feeding? It is a single chamber, double chamber, and a triple chamber. Single chamber, we are giving only for the lipid to the patient. That time you can go for the peripheral line approach. Double chamber is a mixing of glucose and the dextrose. The 3 chambers already we discussed: dextrose, amino acid, and lipid. So these are 3 products is available in the market. So TPN means we have to select in a single chamber or double chamber or the triple chamber. So when you like to administer TPN to the patients, what are the area we have to be focused? First thing, the doctors must have give the prescription or order to the patients, then inform to the dietitian, because they have to do for the calculation based on the body mass index and ideal weight. Then based on the requirement only we have to give to the patients. Patient selections also is very, very important. All the patients we should not give for the TPN. When the patients can able to take orally, or the patients those are having the enteral feeding, we have to advise them not to advise the patient to give for the total parental nutrition. The patient those who couldn't able to take the food by oral or the enteral feeding, or the patient those who are required for the NPO for the more than 5 days, that time we need to give for the enteral feeding. Next, coming to the IVSS, either 2 assess, one is the peripheral or the central. Then again based on the product also, when the doctors is advised to give the product, see the packet, in that it clearly is written peri or the centri. If it is the peri, you have to give the fluid through only peripheral line. In case of this written as a centri, you have to give through the central line. You should not mix the line. If unknowingly, if you are giving for the central line fluid to the peripheral line, the patient may developing the extravasation of the complication. So before giving to the parental nutrition to the patient, what are the area we had to be assessed? Always the baseline data is very, very important. Then only we can able to compare and correlate with whether the patient is developing complications or not. So first we have to check the vital signs. In the vital signs, always focus on the temperature, because the patient also having the old line of the IV line or the center line. If the developing of the thrombophlebitis or the CLABSI, the patient may have the high temperature. That it's an alert sign for us. Next one, the laboratory value also is very, very important. You have to be stressed on the patient's glucose values as well as electrolytes, minerals, and the protein. Because when we are giving the TPN, surely the patient glycemic control stages will be vary. Either the patient go for the hyperglycemia or the hyperglycemia, it will be end up with a complication. The next is the urine output. You have to be monitored in case the patient is having the fluid overload problem. When you are giving the TPN to the patients, it's added value to the patient may developing for the fluid overload problem. So always check that intake output and the urine output is very, very important. As well as you have to check that if the patient is not bedridden, you have to check the weight also is very important. If it is a old line, you have to go for the visual infusion phlebitis assessment. So in the patient is developing the phlebitis, remove the old line and take for the fresh line. So the better thing always you can take for the new line for the TPN is good. The next is already we discussed, we have to check the weight of the patients. Next, we have to check the sugar for the 4th hourly, because the hyperglycemia, if the patient is developing, end up with the complication. Next is intake output. Strictly, you have to maintain the intake output for the patients. We have to correlate with the previous weight and the after infusion weight also. So whenever the doctors is advised to give for the TPN, as we are the nurses and the dietitian, correlate with the patient's clinical conditions, whether if the fluid, if you are giving to the patient may developing any complication or not, discuss with the doctor, then you can proceed. So when we are giving for the TPN, what are the area we have to stress or focus? The first thing, keep the patient in a comfortable position. Second thing, whether the tolerance of the feeding is good or not. Patient can able to tolerance, or the patient either developing any complication. You have to be correlation is very, very important. Next, always give the TPN in the room temperature. If you are keep it in the fridge also, keep it outside for the 3 to 4 hours. Then you can give the infusion to the patient. Next, continue the feed as per the recommendation. Don't use the stopcock. Connected to the infusion pump or the syringe pump and give the exact rate to the patient is very, very important. Then you should not mix any of the medication in the TPN product. Before giving, confirm the patency of the line, center line or the peripheral line, site is functioning or not. Flush it with the Hepsol is very, very important. Check the patency. The patency is not good, remove or take one more line. Then already I said, always you have to give through the infusion pump. We should not set any regulator system. So connected to the syringe pump or the infusion pump and give exact rate to the patients also is very, very important. Next, once it is over, discard the bag. So maximum you can keep it for the 24 hours. More than 24 hours, you should not keep any tubings in the patient bedside. So when we are administering to the patients, we have to focus, is like a critical alert to us. What are the area we have to focus? First thing, we have to focus on the critical alert lab values. You have to give the importance to the sugar level, protein level, and the electrolytes. Any variation with the baseline laboratory services, laboratory values, we have to inform to the doctors immediately. We have prevent the complication. The second thing, we have to assess for the central line infection and the peripheral infection. Next, you have to check for the patient is having any acute lipid intolerance. Like if when you are giving the infusion or after the infusion, if the patient is developing any fever, chills, vomiting, urticaria, you have to report to the doctors immediately. Next, when you are giving for the lipid infusion, the patient may have the palpitation, tachypnea, wheezing. That time also immediately you have to be report to the doctors is very, very important. So it is, if you are not noticing, if you are not reporting to the doctors, the patient may go for the higher complication. The last one, always check for the patient's fluid overload with the help of the intake output chart. In case the patient can able to can able to walk, check their weight daily. So when we can wean the TPN, when the patient can able that rule of thumb one is when you're giving the feeding to the patient till the patient couldn't able to tolerate, but start with the enteral feeding along with the TPN. The next one, when the patient able to tolerate the oral feeding or the enteral feeding, stop the TPN. Complication part I'm not touching. Next speaker is going to explain what is the complication, how we can take care of the patients. Okay, the take home message, how we have to handle the thing. Always the prevention control aspect, wash your hands when you are touching the TPN bag or the IV line bag. The next one, can we keep the things in fridge? Before administer the things, you can keep it in the fridge, but we'd like to, before going to and giving to the patients, keep it in the room temperature for 3 to 6 hours. Okay, so don't, once you take it out from the fridge, don't administer immediately to the patient. So what is the nurse's responsibility? This is not only for the dietitian responsible to calculate and give off everything. As we are the nurses, we should be know what is the pathophysiology, what is the component, what is the calculation, how to calculate, what is the body weight index, ideal weight, what percentage have to give to the patients. We are also have to have the aware of it. So when you like to give the TPN, what are the area we have to be assessed? Always collect the history of the patients is very, very important. What is the indications, whether the patient is needed for the enteral feeding or the parenteral feeding. So compare with the baseline vital parameters and the lab values. Then you can collect past history, any gastric problem is there or not. Everything can correlate with the patients is very, very important. Next is any metabolic disease also is present for the patients also you have to be assessed. So what is the important nursing intervention when you are giving for the TPN? So first one is follow the aseptic technique, then avoid hyperglycemia. If a patient is having the continuous elevated sugar level, the patient may have to go for the secondary complications and the infection. Then check the temperature and vital parameters properly. Check the weight and urine output properly. Do you flush the TPA line? Yes, before and after you have to flush the TPA line is very, very important. We have to checking the patency of the line. You can use the flush, heparin flush or the normal saline. Which is the best vein for the TPN? So my suggestion always go for the central line. If it is the going for the peripheral line, the patient may developing for the thrombophlebitis commonly. So what are the fluids can be given to the TPN? Is a lipid, amino acids and dextrose. Thank you.
Thank you, ma'am, for the wonderful presentation. I now request Ms. Shabita, Housekeeping Manager, to honor Arogya Jaideepama. Thank you, ma'am. Our next presentation is on how to handle parenteral nutrition and enteral nutrition-based complications. Our speaker is Dr. Shivakumar Ji, Consultant Intensivist, Head of the Department, Adult Intensive Care Unit, MMM. He is an MBBS, MD, Anesthesiology, DA and IDCCM with Diploma in Critical Care Management. He has been the Assistant Professor and Junior Consultant of Surgical ICU and Anesthesiology, CMC Vellore. He has also published several papers and is currently with MMM as a Consultant Intensivist, HOD, Adult Intensive Care Unit. We are very happy to have you here, sir. Over to you.
Good morning. Thank you for the introduction. Um, so we have, I think, mostly nursing students here. Do we have any nutrition students also? Okay. Thank you. Thank you for identifying. So well, I'm just going to briefly tell you, very briefly, don't worry, how to handle complications in TPN as well as other nutrition. I think the previous speaker, Jaideep, has clearly told about the complications. So we'll move on. Complications associated with enteral nutrition. I'm just going to put a list which are not, they're not only the complications, there are several complications, but the most commonest, I'm just mouth discomfort and infections. One of the frequently patients complain of this most often. Reflux and vomiting. Whatever feed you give or you plan, sometimes they develop reflux and they might vomit. Not necessarily because of the taste, okay. Abdominal pain and distension. Diarrhea, once again, very worrisome complication in enteral feeding. Then the other thing, the constipation. Okay. See, dry mouth. How do you deal with dry mouths? To drink some water, please allow the patient to have some in between the feeds, sip of water. Even if you are tube feeding the patient, you can allow them sip of water in between so that they can feel better. The dryness lessens a bit. There are several lubricants, several commercially available sprays where you can just spray it, and it kinds of forms a film over the oral cavity and the pharyngeal space, so they don't have to worry about dryness. Toffee means you can give once in a while, but not always, a lollipop or something, so that they might be still swallowing a bit of their own saliva, which is much more sweet. The COVID pandemic, you might have, most of you would have seen most of the patients who are being delivered with the NIV, or it's a mask connected to a ventilator where the air mixed with oxygen is given to a patient via mask, not necessarily via tube. So when you give this therapy, because there's a high flow of air, they will feel very dry in their mouth. So once in a while, give a break, give some water, give some toffee, and continue with your tube feeding and the NIV. All these things we've been doing regularly, so it's been tried and tested. Infection, oral care, once again, some of you might be asthmatics. Even in the COVID pandemic, we've been using a lot of steroids, inhaled steroids. Even in the movies, you see people taking steroids once in a while to prevent asthma attack. So when you take often, you tend to develop a coat, what you call the oral thrush or a candida in the mouth. The treatment, first you need to diagnose it. You need to examine the oral cavity. Once you diagnose, you can give some antifungals which are available specifically for oral application. And if you're using it a bit too often, the inhaled drugs like the puffs, can give it a break or consult your physician or doctor. With regards to patient, you can notify the doctor that there is an oral thrush and we are taking steps to clear it. Reflux and vomiting, I think it's already told. You need to keep the patient in the ICU, in the ward, even in home nursing, as at least 35 to 50 degrees propped up. The gravity helps in forward flow of the secretions, prevents reflux, vomiting. Even if they burp, remember, even if they burp, some amount of food will enter the oral cavity that can get aspirated into the respiratory system. And if you're giving reflex causing drugs, antibiotics, something which you can, other drugs, even painkillers, which can increase the acidity, we can reduce it, avoid it, give a break. The patient has got a pre-existing reflux disease. Don't forget to continue their medications. Don't omit it. Discuss with the physician. If you're giving it via tube, make sure the tube is in position. You can do a burp test, you can do a litmus paper test, you can do a chest x-ray to make sure the tip of the rail tube is below the diaphragm. So if it is below the diaphragm, it is safe to go. So if the tube is already in place and you're having all these problems, reflex, time and again the feed is coming into the mouth, you can advance the tube further into the duodenum, beyond the duodenum, or called post-pyloric space, where the quantity will be, the pooling quantity of the feed and the acid pepsin will be less. Once again, reassess the prescription. Do we need to give this much volume? Can we reduce the volume? Can you reduce the concentration, or can we try a different type of food or the feed? And when you're dealing with vomiting, high NG aspiration, please keep a strict IO. So when you throw off the vomitus, when you discard the aspirate, please include in your output so that we need to replace it with some other form of nutrition. Abdominal pain and distension, quite common when you start the feeds. Do a examination, put your hand on the tummy, feel if there is any gaseous distension. Take a stethoscope and listen to these sounds, kind of gurgling sounds you can hear. That shows that bowel is moving, called bowel sounds. And don't keep the feeding tube end open to prevent air getting entrained into the gastric space. And once again, reassess the feed is being prescribed, whether it will cause more bloating. Do we need the same amount of volume, or do we need to reduce the rate of infusion per hour? Can we increase a bit of fiber content? And also, the patient is on anti-motility drugs. Like patient had diarrhea, you put on anti-motility. Now the patient is having distension and pain. You need to probably stop those drugs. Gastric venting, the patient is upper part of the tummy is full, and you need to notify the doctor or the physician, and you need to keep it to the dependent drainage so the gas comes out. And temperature of the feed, not a bit of a worry, but make sure the feed is delivered at the room temperature, close to body temperature. Diarrhea, once again, first rule out the infective causes. We need to be able to differentiate between dysentery and diarrhea. Both are not the same. Diarrhea is more than 200 ml of volume of bowel movement per day, more than 3-4 times of bowel movement per day, not necessarily loose stools. Dysentery is a different thing. You need to differentiate it. You need to notify the physician, the doctor. And if you're giving any pro-motility drugs, the drugs which will increase the motility, you need to probably stop it. If you're giving oral magnesium phosphate, they are laxatives and purgatives, they'll cause more bowel movement. Like if you're giving before the contrast CT or something, we need to be aware of the effects. So once again, consider optimizing feed administration rate. And sometimes when the tube migrates, see, the tube is in the stomach. With the normal peristalsis, it can move further into the small bowel. And if you give the same amount of feed, same type and same rate, then probably the small bowel will not tolerate it. You need to probably put it back a bit. So you need to do X-ray and assess it. And somebody who's very poorly tolerant to feed, remember, you can give a break, change over to IV feeding, or change the type of feed. Remember, when you're dealing with diarrhea, you need to hydrate. You need to replace the lost electrolytes. So monitor the electrolytes, reassess the hydration, break the feed time, and make sure you chart it out, the number of times the bowel movements. If you're tired, like 10 times a patient passes stools in 2 hours, make sure you document 10 times. And so that we can replace the lost electrolytes and fluid. And a stool culture should be sent if it is not improving, to rule out any infective cause. And any recent change in the feed type should be examined, should be analyzed. And prescription should be probably optimized discussion with the doctor and the dietitian. The patient has pre-existing disease which is not properly treated, then we should restart the drugs. And the patient is on laxatives, once again, please stop it. I think we have covered this mostly. And the hygiene practices, when you deliver the feed, of course, you should maintain hygiene, avoid contamination, even in kitchen feeds, even in formula feeds. Make sure it is delivered without any contamination. When you have any suspicion of contamination, don't deliver the feed. Please discard and prepare a new regimen, new feed. And if the bag is used beyond 24 hours, the set is used beyond 24 hours, please change it. And ask the doctor to perform a fecal impaction. Impacted feces can cause a variety of problems. Notify the physician to do an examination. Malabsorption, including bile salt, means when you in our hospital, especially in gut surgeries, when they remove most of your small intestine, you develop a condition called short bowel syndrome. When you develop a short bowel syndrome, when the length of the bowel is not adequate, the bile salts are not vented adequately from the liver. So the bile salts are responsible for the bowel motility, optimal bowel motility. When that happens, then you develop these problems. So that can be a limiting factor. You cannot do much about it. Constipation, usually it is dehydration. So we can supplement fluids, increase the fluid content, can dilute the feed a bit. You can probably give IV hydration, can add a bit of fiber. The patient is immobile, even with tube in place, you can make the patient mobile into a chair, or you can even mobilize to a side of the bed. Medications, whatever the anti-motility medications, you can avoid. The opiates, commonly used medication, even in tramadol, most of them cause constipation as a side effect. And find an alternative for pain relief and avoid the drugs which causes constipation. And some of them in our country, even especially, they feel a bit socially, not so psychologically, socially, they might not be comfortable using a bedpan or a bedside kind of potty. So if possible, let them use a toilet with the monitor. And in COVID pandemic, we know we hooked the patients to oxygen, they were sending them to toilet. So it's all possible. So unless you sort it out, they might not be able to move their bowel. I think we covered most of it. So make sure you are providing adequate fluid, make sure the patient can be mobilized, provide a choice for the patient to use a restroom, and counsel them. Okay. So complications of parenteral nutrition. Parenteral nutrition is a bit of non-physiological. So the complications were many, but over the years we learned to deal with the complications because we learned to identify it early, and we can rectify most of them, if not all of them. As the previous speaker said, the parenteral nutrition requires a dedicated lumen or a line, usually a central line which is placed in the neck, which kind of the tip is near the heart. We call it as a central line, and it needs to be inserted by an expert, anesthetist or intensivist. So insertion itself has some known complications. Pneumothorax means a punctured lung. Bleeding, because you are inserting into a big blood vessel, it can bleed. Misplacement, you think of putting into one vessel, you might end up putting into some other vessel. So these are, I'm not going to detail about these complications. So line-related complications, I think discussed. So the line-related complications, the main thing is the line sepsis. The line sepsis is not Actually, TPN induced sepsis, it's the line sepsis. The presence of the line is simply acting as a connection between the outside world into the bloodstream. So it's an open highway. So if you're not handling it hygienically, aseptically, over the period of time, the patients will develop infection even when you are not giving TPN. So it is called the CRBSI, or the catheter-related bloodstream infection. It's a severe complication. It's got significant morbidity and mortality. Imagine the patients will have to be given antibiotics, and the stay of the patient inside the hospital, or if they're outside the hospital, they need to be brought inside the hospital. So it's going to become messy. So if you identify it early, we can rectify. The best thing is primary prevention, aseptic precautions. There are several areas the lines can be put, of which is subclavian line, which kind of the experience says when you put a subclavian line and give the TPN, the incidence of infection is less compared to jugular and femoral. The PICC line, it's a mistake actually. Put it last. PICC line is a peripherally inserted central line, which is also equivalent to subclavian. So kindly omit that Roman. So when you're putting a line only for TPN, we are not using it for any other drugs, the incidence of infection is much less. At least if you're putting a line which has got multiple lumens, if you're using one lumen for only TPN, once again, the incidence is less, but not as good as a single line. And we need to have strict hospital policies in terms of maintaining a central line, handling the TPN. Right from the insertion till it is removed, the aseptic precaution needs to be maintained. Only professionals with specialized training, like anesthetist or intensivist, should be putting the line. So anybody can put the line, but you need to know that you need to follow a set of procedures. Otherwise, you will be compromising the asepsis. When you suspect line sepsis, like any sepsis, when will you suspect? When your patient is having fever, new onset, suddenly the patient has fever, and when you look at the line, there is some discoloration, like reddish, blackish discoloration around the insertion area, you suspect. Better to be always suspicious than feeling, oh, fever will settle or the color is okay. So notify, take the further steps. When you suspect line sepsis, it's better to stop the TPN at that point of time and immediately send the cultures. The blood needs to be drawn through the central line, and you need to send a paired culture from a distant site as well. And while we wait for the culture, we can start the antibiotics and stop using the line too. And you can use a different line. If you're more worried, you can immediately change the line. So not only that you should be suspicious, not only that you should take the cultures, you should stop using the line, stop infusion of TPN. And if your patient needs the central line for some other indication, you need to put a new line at a different site. Culture lines are passed, means some bacteria grows. The microbiologist will be telling you which antibiotic will be appropriate. So you need to change, adjust, or continue the antibiotic. Thrombus and phlebitis. See, these parenteral nutrition solutions are very concentrated. So if you give it through a peripheral line or even a central line, they can develop inflammation of the vein that is called phlebitis. So how do you say what this means? If it is isosmolar or not, means if you are giving a solution where the concentration is above 850 milliosmoles per liter, you need a central vein where the tip is near the right heart. So it is draining into a high flow area and a large vein. So obviously there's a less chance of developing phlebitis. When it is less than 850 millimoles or even lesser, you can try and give it through a peripheral line that is called peripheral only TPN. Sorry, peripheral TPN, which can be given centrally. But when the concentration is high, it should be given only through central line and do not give through peripheral line, because peripheral veins are small and low flow, so they can easily develop phlebitis inflammation. When you see the white part, the milkish part, is the lipid part of the TPN, you might have seen in the pictures. So that gives a kind of coat to the vascular endothelium and reduces the pain and produces soothing effect, just like you apply it on your lips in the winter. Better to avoid otherwise. Serious consequences of phlebitis: when the inflammation develops, the platelets in the blood goes and attaches to the veins. Sometimes it can attach to the entire length of the vein up to the heart, where we call the superior vena cava, the largest vein in the body, one of the largest veins in the body. When it is obstructed, the entire limb will become swollen, and you might require to dissolve the clot or surgically remove the clot, which are very, very, very easily said when done. Better to avoid. Line blockage, every line gets blocked. It's like our pipeline or drainage system. It needs to be flushed. Often, not often, regularly after and before starting a TPN therapy, preferably with heparin containing saline. I think thrombolytic agent should be given in discussion with the treating physician only. Because the thrombolytic solutions not only dissolves the clot in the line, it is going into the body, it might cause effects elsewhere. So the main thing is the metabolic complication, especially for the dietitian. So acute therapy, metabolic complications, refeeding syndrome, very well discussed. It can happen with enteral as well as parenteral. Hyperglycemia, low sugar, high sugar, electrolytes, because we think we're giving TPN, they might not contain adequate electrolytes. Hypertriglyceridemia, giving the lipids, it can cause hypertriglyceridemia. Cholestasis, mostly related to the bile salts. The chronic therapy like home TPN, people who live with short bowel, sometimes even without any bowel, they might be on home TPN. So they can develop a liver disease, cholelithiasis, which is the stone in the bile tract. Metabolic bone disease, when the bones become brittle. Micronutrient imbalances, that's all chronic therapy. So refeeding syndrome, it can happen with PN and EN. So it's a life-threatening complication, but only rarely occurs. So we should always be suspicious. So when you start feeding a patient who's not been nutritionally well for a period of time, we need to start in a la carte or like increments, like 40% of daily requirement, 50, the tolerate 60, then over probably a week's time, we can achieve 80% to 90%, and later probably 100% of his daily requirement. Then you can supplement, you can try and supplement whatever he lost over a period of time. So if you don't do that, what happens? Yes, this electrolytemia, remember, when you don't eat food for 2 days, what happens? When you don't eat food at all for 2 days, like you fast, you Lent or whatever the festival, what happens? Oh, lady, yeah, you're right. Muscle breaks down. But there is a point. So when you are well nourished, of course, you have glycogen stores in the liver that will give you nutrition for 2 days. But if you're not eating even prior to that, then your muscles will break down. You go into a state called ketosis. You might be knowing the keto diet, no? Ketosis, you lose. So remember, the malnourished people will not have glycogen or the fat content. So when you are very respectfully saying, when you are overweight or obese, when you go to keto diet, you have adequate stores which will last for days. So you can tolerate ketosis better, but malnourished cannot. So when they are not taking food, they have developed a sequence of ketosis where they develop acidosis, the muscles break down. Not only that, and they maintain their electrolytes. So we spoke about only proteins, calories and lipids. What about the electrolytes? They're not taking adequate amount of that too, because nobody's eating only electrolytes or not food. So most of the electrolytes, especially the important electrolyte, potassium and magnesium, are inside the cells. But other important electrolyte, the sodium, is outside the cell. They kind of move in and out to maintain a kind of neutrality. When you give food suddenly after 2 weeks or 3 weeks into the tummy, this metabolism alters from ketosis to normal metabolism, glycogenesis, glycolysis. Then they develop a condition, a feared condition called hypophosphatemia. All over the body, all the cells have these pumps, or it's called the sodium, potassium, magnesium, ATPase pump. So the pumps need these electrolytes. If they don't have these electrolytes in adequate amount, they become weak. So heart muscle, when it becomes weak, they show arrhythmia. The arrhythm or the contraction varies. The respiratory muscle becomes weak. The diaphragm becomes weak. Then you won't breathe properly. You will end up in cardiac and respiratory failure. Of course, the skeletal muscles are anyway weak. Now it's going to become more weak. It is also associated with hypokalemia. The potassium, the calcium, magnesium, everything will become altered. And lactic acidosis, whatever the lactate which is collected during the ketone will come into the circulation and produce a kind of a stormy condition with arrhythmias. So cautiously start the nutrition. At least 50% is a guideline. You can start less for 24 hours, then take it as it goes. Gradually increase over the next few days. During the time, monitor your electrolytes quite frequently than the usual thing, and put them on a continuous ECG monitor, an ICU or a HDU, and replace phosphate, potassium. Intravenous vitamin B1 is thiamine. Thiamine is an important cofactor in the the sugar metabolism. Inadequacy can cause lactic acidosis. So you try to replace it all IV initially, then you can slowly give it through enteral, because the phosphate, magnesium are all purgatives. So if you give it, replace through enterally, it can produce diarrhea. Hyperglycemia, very important, means in the ICU, we measure sugars very frequently. So when you go to the ward, the patient's still on TPN, you need to maintain euglycemia. Rule of thumb is maintain between 150 to 200. When you start TPN, once again, when you start TPN on a patient who never had food for a week or something, when you start TPN, we tend to start a bit lesser than the prescription dose. Otherwise, the insulin response to sugars will be less. Like when you connect TPN, which is rich in sugar, to a patient at 100 mLs per hour, the sugar will shoot up to 300 milligrams per deciliter, and will take the body a bit of time to come up with the insulin response. So you need to supplement with insulin or reduce your TPN intake. So if you give hyperglycemia, then the body will have to excrete the sugar through urine, so they will become dehydrated, and the chances of infections are high. So when you gradually start, always monitor sugar. And when you have hyperglycemia, the electrolytes also will get washed out, replace the electrolytes. The TPN tends to have a little bit of lesser sodium than the body requires. Probably you need to add a bit of sodium after discussing with your physician. And of course, you need to monitor sodium. Hypertriglyceridemia, which happens when you overfeed them. Means you give lots of TPN. The TPN, the fat kind of coats the liver, producing a condition called fatty liver, which can cause a bit of problem, but more with chronic, less with acute, less in acute therapy. You can give a lipid-free, means you can avoid that milky white part. You can give the dextrose and amino acid part for a while, or you can alternate. You can give lipid-free days, so that this doesn't happen in long-term patients. Abnormal liver function tests. See, when the patient is developing abnormal liver function test after TPN, you need to make sure that it is not because of the primary problem. The patient is already in the ICU or the ward for some problem. Those problems can cause abnormal liver function test, not only the TPN. like the pre-existing alcohol intake, ongoing septicemia, or the patient will be having hepatitis, waiting for transplant. So TPN might not be primarily causing the issue. Overfeeding, I told you anyway. Hypertriglyceridemia can be a problem. See, hypertriglyceridemia, again, like I'm saying, thousands can cause a condition called acute pancreatitis, which is a medical emergency, debilitating disease, painful disease. The prognosis can be tricky. So in those conditions, remember, TPN is unlikely going to cause hypertriglyceridemia, but you're starting TPN for such patients, make sure you avoid lipids or consult your gastro or intensivist. Chronic metabolic complications, we might not come across much in our practice in our country, but it's quite common in the developed world, Western world. So patients with liver disease, patient can develop liver disease. I told you the short bowel, less than, if the patient is having only less than 1 meter or 100 centimeter of bowel, normally we tend to have like 3 times more. They are labeled as short bowel. Some of them tolerate it well, like the bowel is removed after an trauma, like an accident or a tumor removal, but some of them will not tolerate it. So they develop cholestasis where you need to supplement bile salts. Children tend to develop, once again, liver disease with lipid formulation where it can be avoided. The omega-6 fatty acid is considered to be a bit pro-inflammatory. So when you think if there's an inflammatory response, you can reduce or change the type of feed. Cholelithiasis means stone in the bile tract. So once again, the bile salts intrahepatic circulation is not adequate, especially in short bowel. This can happen. You need to give a break in the feed. And cholecystitis is the inflammation of the gallbladder. Obstructive jaundice, cholangitis is the infection of the biliary system, and pancreatitis, as I told you, is an inflammation of the pancreas. Can all happen in chronic patients, like months, sometimes years on TPN. Metabolic bone disease means when you give only TPN, then you might not be absorbing, means you'll be using up all your bone to produce calcium, to maintain neutrality of calcium in the serum. So you might develop metabolic bone disease, brittle bone, osteoporosis. So you need to supplement it IV if enteral is not possible, and you need to add vitamin D3 for the kidney to convert. And if your patient is immobilized, if you immobilize, the bone tends to break because the deposition is lost, the calcium deposition is lost, you need to mobilize. The patient is on steroid treatment for some other disease long term, we need to give a break, or we need to talk to the primary physician. Prevention and treatment include supplementation. I told you, bisphosphonates, it's used in hypercalcemia. It's usually seen in tumors producing calcitonin. Anyway, it's beyond the discussion of our topic. Micronutrient imbalances like selenium, it's all difficult to diagnose. I mean, better to give it than wait for a symptom or a sign. Because regular measurements, remember, most of the labs don't do these measurements, so might as well just give it, have a formula for treating home patients or chronic patients, have a protocol rather. The clinical manifestation may be non-specific. By the time you realize this is because of that, like biotin or vitamin B12, which causes hair loss, or neurological symptoms, might as well replace it. So you need to have a working formula. Okay, I'm done. Any queries? If you are not going to ask, I'm going to ask you. Who wants to be asked? The dietitians, nutritionists, or our nurses? Doubt it, how much out aspiration is significant. You're saying, okay, so we daily we get the question, doctor, we aspirated 200 ml of the feed or 600 ml of the feed, which has come back after a bout of therapy. Do we need to stop the feed? I think we don't need to stop the feed. We can probably give a break or 2 hours. There are a variety of prokinetic agents available. Remember, all of them have some side effects. Some of them produce problems with the heart rhythm. So I need to notify the physician. I need to start those drugs and continue the feeds. And whatever is aspirated, like if you aspirate 600 ml, you need to replace it IV, because if you're not going to achieve it, because you're going to reduce the amount of feed because the patient is not tolerating, you need to whatever the last weight needs to be replaced. Only one question. Everybody understood. So TPN will cause sepsis on its own? No. See, 10 years ago, at least, when you say TPN, the surgeons and the physicians will say TPN infection. It's like a single word, TPN infection. And we have a lot of data. None of them prove that TPN itself will cause infection. If you maintain that line handling to the core, means if you're connecting TPN to one lumen in the morning and next day you're connecting that, means if you're not practicing it strictly, it will cause. But if you're maintaining the single lumen or single catheter and 24 hours infusion with lipid containing and non-lipid containing less than 72 hours, it is as good as a patient is having central line without TPN. You get it. Central line mottum irundhalum, TPN board central line irundhalum, infection rate same da. There is no data suggesting that TPN increases infection. Okay. I think we need to have a protocol. I think if you're not touching it at all, like you should connecting to the pump and hanging it, I think 24 hours with the milky, the lipid ones. Non-milky, the transparent ones, you can give it 2 days, 3 days. One bag. I'm not meaning this because you're not touching the set at all. When you're touching the set, I think we need to 24 hours. You need to just discard. If you're discarding the set, you need to discard whatever the remaining solution also. No, we have done that. We have done that. Means when you're starting enteral nutrition in very oligots like probiotics or some custard or something, we tend to give full parenteral nutrition. Remember, at one point of time, they might not feel hunger when you give full TPN. So you'll be thinking that we are giving a hybrid therapy, but they need to have that hunger mechanism to eat. Also thirst. Thirst is a kind of hunger mechanism. You tend to eat. Otherwise, they'll just lie flat. TPN is going. So you need to give break. It can be done. It should be done. It should be done. There should be a period of overlap where you can try out the interfeed is acceptable, adequate. Then you can switch it off. I tell you, one day, you need to have a protocol. So what I'm saying is it should be a uniform protocol for the ICU or the hospital, but 124 hours is our country. So don't go by Western protocol. So our country, 24 hours sounds good. So, amino, I don't want to comment on that particular product. If you say amino acids, especially when you're dialysing a patient. So dialysis, there's a filter which kinds of filters your blood and gives back. There will be loss of the filter is made in such a way that it will not filter albumin. So otherwise, if you filter albumin, then everything will go away. Kind of. We're giving amino acids on those patients where there's a lot of catabolism, patients on dialysis, because there will be some albumin loss. 100% it is not safe. Like 10% albumin loss will be there for every session. So on those patients, you can give amino acid only. They'll be eating otherwise. But with eating alone, they cannot bring up their protein amino acids level normally. Can give. Remember, this amino acid, especially these formulations, can tend to exacerbate megaloblastic anemia. You need to give B12 injection simultaneously. Personal opinion is peripheral line. You don't have to worry about it. But peripheral line is good for this. I think when she pointed out, good for this hybrid therapy where patient is still eating, but not adequately. You can give one bag, one line once. So if you're using that line, peripheral line for one TPN, that you should be giving only TPN, and you should be giving only one bag. After that, the line, everything should just come out, because there's a threshold for your vein. So if you keep on giving bag after bag in one line, it is going to get phlebitis. Or the patient is not on any form of enteral nutrition, then it is better to have, like the patients in ICU where the patients are sick, better to put a central line and give them that. The patient is already having central line. You want to start a therapy where a lumen is available. I think I would still recommend the peripheral one to start with. So peripheral or central will be decided by the patient's oral or the enteral adequacy of the nutrition. If they are nearly adequate or they're tolerating, better to go for the peripheral. But it's going to take a long time in the peripheral. That's all. So can I ask my questions now? Thank you. Thank you.
Thank you, sir, for the wonderful and interactive session. I request Ms. Deena George, Assistant Manager Communications, to honor Dr. Shivakumar. Thank you, ma'am. Thank you, sir. Our next presentation is on selection and usage of devices in parental nutrition, enteral nutrition, and IDPN. Our speaker for the event is Ms. Sharmila Parthiban, Assistant Manager, Fresenius Kabi. Over to you, ma'am.
Good afternoon to all. Thank you for this opportunity. Today we will be talking more about the practical aspects as a nurses, what you have to do when the patient is on enteral, on the therapy of enteral nutrition or parental nutrition. I will not be going slide by slide because most of the points have been covered by my previous speakers, thanks to them. And a few points, whichever it has not been highlighted or which need to be more emphasized, I'll be doing it. And I think this is very basic, but this you have to focus. Nutrition is very closely related to anatomy, physiology, and the biochemistry. And I hope everyone will agree with me that if the person is having some issues in these 3 points, then only they will land up in the hospital. And if you look into this, everything is closely related to nutrition. And this is a very good saying by Professor George Herbert. He says, whatsoever is the father of disease, the cause of a disease can be sepsis, surgery, burns, trauma, anything. But an ill diet joins as a mother, then it produces complications like mortality and morbidity. And I'm not very keen on that, like, going into that. You should know what is the difference. There was a question also, what is the difference between enteral and parental nutrition? Enteral nutrition, you are giving a food. Parental nutrition is like a drug. So you should have a cautiousness when we are giving a parental nutrition as well as enteral nutrition. In enteral nutrition, you are giving carbohydrate, fat, protein. But in parental nutrition, you are giving amino acids, dextrose, glucose, or like for fat, you are giving triglycerides. So enteral nutrition needs some amount of digestion and absorption, whereas parental nutrition does not require digestion and absorption. Okay, so this is a very important or very crisp difference between the enteral and parental nutrition. Enteral nutrition is more physiological. I think you all will agree with me that you need your GI tract to be used. So enteral nutrition is more physiological and preferred route and first choice. Always parental nutrition at the last bench only. If enteral nutrition is not possible, or if enteral nutrition is not meeting 80% of the calorie and 100% of the protein requirement, then comes like the other person asks, can I give both? Yes, you can give both, which is called supplementary parental nutrition. Enteral nutrition to maintain the gut immunity or gut integrity in that case, but parental nutrition to meet the calorie and protein requirement. This is called supplementary parental nutrition. Yes, you can give it. And actually, there is no solution in the market which is a total parental nutrition. Total parental nutrition means you should give carbohydrate like glucose, amino acid, lipids, electrolytes, vitamins, trace elements. No, none of the all-in-one bags contains everything together. What they have is carbohydrate, protein, fat, and some electrolytes will be there, and some vitamins like maybe fat-soluble vitamins like vitamin E will be available. So you have to, whenever you're giving parental nutrition, you should keep in mind that you should also supplement the vitamins and trace elements separately, or you should keep it in mind that it is not forgotten because they may land up with more problems. This is any possible way should be given. As you know, there are two types. Parental, you split the word parenteral apart from GI tract. Enteral means GI tract. If you are giving nutrition apart from GI tract, it is called parenteral nutrition. And obviously we use the intravenous line. Okay. How will you decide? Okay. It's not that because the bag is having peripheral or central. How will you decide whether I should go with peripheral parental nutrition or with central line parental nutrition? There are 4 guidelines. One is how long you are going to give parental nutrition. If it is less than 2 weeks, then go for peripheral. Oh, sorry, if it is less than 2 weeks, yes, you can go for peripheral parental nutrition. If it is more than that, like sometimes we have a patient who are more than 5-10 years also on parental nutrition. So it is obviously they should go for the central line parental nutrition. The second one is the osmolarity. The osmolarity, which is more than 3 times of the plasma osmolarity, then it should be given in the central line. Plasma osmolarity ranges from 285 milliosmosis to 300 milliosmosis. So we take it as 300 into 3 times 900. Up to 900, you can give it in peripheral line. More than 900, you should give it in central line. Why don't I give? Okay, let me give it in peripheral line itself. What is the problem? See, the problem is they lead with phlebitis, thrombophlebitis. If proper treatment are not given, I've seen they go for the amputation also. So osmolarity, and they'll have a severe pain like shock, electric shock pain. The patients will be experiencing it. And in ICU, saving each vein is a very important one. So you have to, even the bags are written as peripheral, please check the osmolarity and the glucose and amino acid concentration. See, whatever the guidelines I'm giving, it is not only for parenteral nutrition, any IV fluids, it stands for that. Okay. And what is that? The third one is the concentration of glucose or amino acid. If the glucose or amino acid concentration is more than 13%, you should not give it in peripheral line. Do you give 25% dextrose in peripheral line? Do you give 25% dextrose in peripheral line? Pin drop silent. Oh God, I think you give, no? Sometimes. Only we give 25% dextrose in peripherally when the patient is going for hypoglycemia. Otherwise, we never give more than 13% through the peripheral vein. So this is the third guideline. And the fourth one is and you also should understand the osmolarity. The other name for osmolarity is water pulling capacity. Okay. The more the osmolarity, it pulls water from the outside, from the tissues. That's why you get phlebitis and thrombophlebitis. So you have to maintain the peripheral line guideline. One is the osmolarity should be less than 900 and the concentration of glucose and amino acid should be less than 13%. And the fourth one will be your I'm not going into these things because it's already covered. And the fourth one is the hospital protocol. Some hospitals say to avoid the infection or to have a proper maintenance, they say parenteral nutrition means it should be only in the peripheral line, or it should be, some hospitals, they say it should be only in the central line. Okay. And once I get the product, the next is, as you know, it will have two covers. One is the outer cover and the inner cover. Check it, whether any leakage is there or any particles are there. If not, you can open it. The next step will be you have to insert the IV set. There are three types of IV sets you have, I think so. One is the blood transfusion set, should not be used for parenteral nutrition, especially when you are using the lipid emulsions, because the filters which the blood transfusion set does not allow the lipids to pass through. The second one is, sometimes you can see the air vented IV sets. The atmospheric air and the lipid should not come in contact. They go for a lipid peroxidation. So you should not use the air vented IV set. The only thing is non-air vented IV set should be used for parenteral nutrition. Okay. And unfortunately, the way you are working, it has only the air vented. Make sure the air vent is closed when you are administrating the parenteral nutrition. Pediatric, that is especially the neonates, when you're giving lipids, see, if imagine this is the lipid bottle, you should cover it with aluminum foil or a cloth or whatever, like it, the light should not pass through. So you should cover it from the bottle and the IV set till where you are connecting it to the baby. Okay, it is only for the NICU. Why? Because the baby in NICU, the babies may have phototherapy. The ultra UV light will peroxidize the lipids. So that is why you should cover. It is not for the adults. Okay. So now we have seen the IV set. So next is, I'll also show you how you can mix the bag. It's only a 1-minute video. And once you mix it, okay, Once you mix it, you put the IV set, and as you would have already checked how much per ml per hour you should give. Imagine if they say it is 100 ml per hour, start with 25 ml per hour. Mostly you think that we wanted to check the whether the patient is tolerating or compatible. Not only that, I think if you check the central products, they have 40% dextrose, or sometimes I've seen one product with 65% dextrose. Imagine I'm a normal person, and if you're giving 25% dextrose to me as a bolus, what will happen to me? Like sir also, he was also discussing on that. I will go for hyperglycemia. So sudden push, that is bolus of 100 ml of this high concentrations may lead the patient to hyperglycemia. And in ICU particularly, they'll be on a tight glucose control. So you should step up. Okay, slowly you should step up, and then you can give it. You can give it for 10, 12, 24, whatever the amount, not more than 24 hours. Because nowadays the newer lipid emulsions are coming with soybean oil, coconut oil, olive oil, and fish oil. It's a 4-oil combination. So they are all natural source. These natural source, you cannot keep it more than 24 hours once it is mixed with other products. So not more than 24 hours. So whatever the time period you can give the parental nutrition, once you're going to stop, imagine you have started at 8 a.m. today, and tomorrow morning 8 a.m. you're going to stop. Again, you step down. Not directly, you should not. Like 8 o'clock is over, bag is empty, I'm going to stop. What will be the reason why we should not stop like that? Any guess? I told you the concentration of glucose is very high sometimes. Okay. When the concentration of his glucose is high, the insulin level also will be very high. If you suddenly stop it, the insulin will be high. There will not be glucose supply. So patient may go for hypoglycemia. So in that case, this is the reason you have to step down. Sometimes due to the workload or something, you will not be have a time every half an hour or 15 minutes once to step down. So you request the doctor whether you can give 5% dextrose or 10% dextrose as a maintenance dose for 2 hours. Then you take the order so that you can avoid. Always, every day, whether the patient is a diabetic or non-diabetic, after completing the parental nutrition, after an hour, you check the glucose level to avoid hyper or hypoglycemia. And diabetic is not a contraindication. However, you give the parental nutrition, whatever the hospital protocol, according to the protocol, you check the glucose level and then you give insulin. Okay, so as per the doctor's call, you can give insulin. There is no contraindication. So once you're starting, okay, today, if you're starting parental nutrition, the first day you should check the electrolytes, glucose, lipid profile, and LFT. It is a must. It is a base value. And then glucose, every day you can check. Electrolytes weekly once or 4 days once. Lipid profile and LFT 10 days or 15 days once you have to check. Some doctors, they may ask you to give window period when they are checking the LFT and lipid profile. What is this window period is? If the doctor wants the window period, that means if you're going to take the serum sample at 8 a.m. in the morning, by 4 a.m., you should stop the parental nutrition. Okay, this is called window period. But some consultants, they say no need, because every hour or minute the metabolism is taking place, so no need like that. So you can also look into that. And the second one is when you're taking the blood samples when the patient is on parental nutrition. One day we got a call from one hospital saying that patient is on parental nutrition. We are collecting the serum sample and the sample is coming in white color. So we rushed in and we found out they were giving parental nutrition in this vein and they are taking the sample. Obviously, it will be like that only. So always try to switch over the extremities and take the samples and send it. And parental nutrition, yes, you can refrigerate when it is not in use. It is always written as room temperature. The room temperature, what they mention is 25 degrees, not less than that or more than that. So you know our condition, so always try to maintain it in 25 degrees. If you are keeping it in refrigerator, when the patient is away for the scan or something, bring it to the room temperature and use it, okay? Never ever add any medication in the enteral and parenteral nutrition. It's not that it is going to spoil the product. It will reduce the efficacy of the drug. It will reduce the bioavailability of the drug, and it also alters the kinetic. Kinetic means the function. The function of the drug itself will be changed if it is added into the bag or the enteral nutrition. So I think the dietitians or the nutritionist, if you ask, they will give even 1 day workshop. They will take food drug interaction and drug food interaction. So you should be very careful about, okay, the patient is having a one single lumen central line. How will I give the medications? Always double flush for the parental nutrition. Stop the parental nutrition, flush the catheter, give the medication, again flush the catheter, and then you start the parental nutrition. Okay, so these are the some points which I wanted to share with you before I go for another 2-3 slides. I just want to tell you regarding the enteral nutrition. They have given a full discussion on enteral nutrition, but try to follow each and every possibility to maintain the or enhance the enteral nutrition, because enteral nutrition will define your immunity. I hope you all agree with me. You have the probiotics like the E. coli, which helps in digestion and absorption. Okay, this is very good. They are good. They are called as a good bacteria as long as they stay only in the small intestine. If you are not feeding the patient long time, okay, the lining membrane, okay, that will shed, that mucous membranes will shed off. That is, atrophy will happen, and this E. coli will mix in the blood, and the blood will carry this E. coli anywhere to the body. If it goes to the brain, it's called meningitis. If it goes, it causes pneumonia to the lungs. And if it goes to the peritoneum, peritonitis. If it is mixed fully in the blood, it is called septicemia. So enteral nutrition is going to determine the immunity of the patient. So try all possibilities to give enteral nutrition. But unfortunately, sometimes we cannot because of the flow rate limitation and everything. So in that time, again, you have to give at least 1 ml per hour. I think, hope you know that 1 ml is equal to 20 drops per minute. So at least you give that. For that, you have some, continuous feedings can be given. Yeah, through the different, gravity bags are available, and the enteral nutrition pumps are available. Usually you have these gravity bags where you can open it, pour the feed, and actually you'll have a roller clamp for the gravity bag. In that roller clamp, you can adjust it. And then this is a very important one because it is called Ian lock, that is purple color. Internationally, purple color connections meant only for enteral nutrition, not for anything else. Why? See, imagine if it is like this worldwide, what happens is, unfortunately, by mistake, people are connecting this gravity enteral bags to the IV line. Okay, it's not only India or Chennai or anywhere else, it is internationally. So they have given color coding for everything. That is why this is the purple color. So if it is purple color, it should be connected only with the enteral route, and you have a white and cream for the IV lines. To avoid misconnection to the IV line, these purple colors are given, and you can give it. Usually you have a separate medication port. Why I have taken this is, see, sometimes you have, like in Tribulum, you're fortunate enough that you get the feeds pre-mixed and it has been given to you people. But if the place is there where you have to mix, or you have to teach the people to mix it, what they will do is, see, if I say you take 2 scoops of the protein or Carbipro and mix it, what they'll do is, it's always better to have the shakers, because you will not have much problem. One thing, never ever mix the enteral nutrition products into the hot water or hot milk, because the moment you mix it, the protein, fat, everything is broken down. So you give only the color water, never ever, because even at home, what we used to practice, once the milk is in boiling condition, take 1 glass of milk, put the powder, because it's easy to mix. Otherwise, lumps will be there. That is the problem. But you should not do it. You can see the instructions also. It will be written either warm water or cold palatable water to retain the nutrients. So what they will do is, it's better to have this so that you will not have any lumps in it. Sometimes they take, and imagine that they have to take 2 scoops, no? So they will add the powder and then they will measure the water. What will happen? The volume of fluid will come down and the solid is high. That is, the powder amount is high. It will increase the osmolarity. Always you keep it osmolarity, the other name is water pulling capacity. So high osmolar fluid in the stomach and the intestine, it pulls water from the tissue and it leads into diarrhea. So always you should measure the water, add the powder, and you mix it and give it to the patient. Okay. And see, the order is for 2000 ml per day. That is, they are planning to give fluid of 2000 ml. Don't prepare at once. Whatever is needed, every 4 hours, once only you have to prepare the feed and give it to the patient. Okay. And there was a question about actually, aspiration is not the correct word to be used in the enteral nutrition. What we are checking when the amount of fluid in the stomach is called GRV, gastric residual volume. We are not checking that. It's not aspiration. What we are checking is GRV, gastric residual volume. How much? The guideline says up to 500 ml within 6 hours is allowed. More than that, within 6 hours, you should stop or think about starting parental nutrition. Till that time, you should continue parental nutrition. Okay. And whatever you're getting it out as a GRV, up to 500 ml, it has to be infused or re-fed with the patient, so that the amount of juices, pancreatic juices, whatever the gastric juices, can be re-infused. Okay. With this, I'm done with this, but I just want to give you a brief introduction to IDPN, intradialytic parental nutrition. That is the difference is always we connect the bag, that is all-in-one bags or the amino acid solutions to the patient, peripheral or central. Here, we are not going to connect it with the patient. We are going to connect the IV set with the mission, hemodialysis mission. Okay, so that is why it is called during the dialysis may be 4 hours. If it is less than 4 hours, then IDPN is contraindicated. So if it is 4 hours, during this 4 hours, we are planning to give parental nutrition. Actually, there is a different types of screening and assessment tools are there. With that, they will find out whether the patient needs. In abroad, they do intraperitoneal parental nutrition also. Like I think you people would have seen the CAPD. With the same technique, they give the parental nutrition. But in India, we in some hospitals, they follow IDPN, which is called intradialytic parental nutrition. Okay. The criteria, as I said, it will have a subjective, it has a subjective global assessment. And as per B and C is, if it is indicated, then they go for the parental nutrition. Because if you go deep into that, the renal disease itself creates a malnutrition. And during dialysis, they lost a lot of protein also. Okay. Some places they give amino acids alone, but when you give only amino acids, they are used as again as an energy source. So it's always better to give glucose, amino acid, and lipids. This is what I was telling you. So when you want to connect parental nutrition, you do everything. Once you connect the patient with the hemodialysis, I think the dialysis technicians and the nurses, they know how to connect the patient. Once everything is done, after 15 minutes of initiation of dialysis, you connect the IV set of the parental nutrition in this venous drip chamber. And that is called IDPN. Okay, it is a slow and continuous infusion from the start to end of dialysis. First 30 minutes improves individual tolerability and rare cases. IDPN is always, you can start with 8 ml per kg per day. You cannot give 40 ml, 50 ml. No, it is only 8 ml per kg per day of IDPN session. Whenever they are coming, if they are coming for 3 days, only 3 days. If they are coming for 2 days, it is 2. Maximum, you can go 16 ml per kg per day, not more than that. That means you should not exceed more than 1 liter in per dialysis. Whatsoever the month or years you are going to give parental nutrition, you should not go more than 1 liter. And then how? See, the next question will go. Already patient is in fluid overload because of the renal. How it is you're going to adjust it? They know how much. They calculate the ultrafiltration volume. Along with that volume, you add how much ever volume of fluid you are going to give as a parental nutrition. And then the technician will set the flow, and so that the patient will not land up with fluid overload. Remember, when you are doing the IDPN, the patients will be losing 5% of amino acid, whatever you are giving. Okay, and IDPN should not be started if the blood flow rate is less than 200 ml per minute. And compatibility of the IDPN mixture needs to be assured. That you can find out from the manufacturers. Special considerations like antibiotics, iron, and blood products which are administered during dialysis should not be infused through lines used for IDPN. It's not only for IDPN, any parental nutrition. So you should stop the IDPN, continue with your main iron supplementation, blood supplementation, and then you can give it. Okay, so this is again, start, step by step they have given. The information is also available in Google. You can take it up. And IDPN is always given when the patient is not able to meet 80% of the enteral or 100% of the parental nutrition. Again, the first route of choice is oral. If oral is not possible, enteral. And if enteral is not meeting 80% of the calorie and 100% of the protein requirement, then supplementary parental nutrition. Only in cases like where the high fistula, where enteral nutrition contraindications are there, then they go for this so-called total parental nutrition. Okay, and mainly for if you wanted to add glutamine into your parental nutrition or enteral nutrition, always you keep it in your mind when the patient is in shock, nutrition is absolute contraindication. And if it is glutamine, if the patient is having hepatorenal syndrome, then it is also a contraindication. And finally, these bags, okay, is meant only for 24 hours. You cannot use it more than 24 hours. That is also very important. I think this is all I wanted to share. Before I complete, I just want to show a video and then we can close it.
Parenteral nutrition is a form of nutritional support given intravenously with an IV pump or gravity infusion. Parenteral nutrition consists of amino acids, carbohydrates, fats, vitamins, and minerals. It aims to prevent and restore nutritional deficits, allowing the bowel to rest while supplying adequate caloric intake and essential nutrients. Insertion of intravenous catheters should be a sterile procedure. Monitoring for complication is important while a patient is on parenteral nutrition. The care and maintenance of access site is key. Line selection. Always use central venous access for long-term infusion, more than 2 weeks, and peripheral line for short-term, up to 2 weeks. Central venous access should be used for parenteral nutrition with higher osmolarity. Select central veins such as subclavian vein or basilic vein, preferably for cannulation. Observe maximum sterile barrier precaution while inserting central venous catheter. The insertion site is a major source for catheter colonization. This and the surrounding area should be cleansed with chlorhexidine, 0.5%, in alcohol 70%, or Hydrex before applying sterile drapes. To facilitate viewing of the site, an occlusive transparent dressing should be used, as this will reduce the number of times the site is disturbed. Disinfect catheter hubs, ports, connectors with 70% alcohol before using the catheter to reduce the entry of microorganisms causing catheter-related infection. Once the catheter connection has been cleaned, a needle-free IV administration device, bioconnector, applied, placing a shield around the catheter hub to ensure it does not come into contact with skin. Above measures help reduce the incidence of catheter-related infection. The line can be coiled on patient's chest until the position is confirmed and feeding is ready to start. Keep the dressing over the catheter exit site clean and dry. Change it if it becomes soiled or loose. Replace central venous catheter line every 7 days, or if there are any sign of infection, and peripheral line every 72 hours, or if there are any sign of infection. Change the parenteral nutrition bag and IV tubing every 24 hours interval. Maintain nurse-patient ratio as 1:1 to maintain minimum handling of tubing, infusion change, manipulating catheter, and entry site. Administer parenteral nutrition following strict aseptic conditions. Do not use parenteral nutrition if the bag or bottle is leaking. Do not use expired parenteral nutrition products. Inspect parenteral nutrition solution for the following: clear and uniformly mixed solution, lumps or sediments in the solution, color changes of the solution. Strictly maintain the prescribed flow rate using an infusion pump. Always start infusion slowly. Obtain lab values of blood glucose, sodium, potassium, magnesium, and albumin levels before starting parenteral nutrition. Monitor for the following: central line associated bloodstream infection, increased parenteral caloric intake, and poor catheter care are associated with increased risk for bloodstream infection in patients receiving parenteral nutrition. Monitor and report tachycardia, hypotension, elevated or decreased temperature, increased rate of breathing, decreased urine output, and disorientation and malaise. Monitor patient for white blood cell count and report if it is elevated. Peripheral line associated bloodstream infection. An increased risk exists due to the infiltration of parenteral nutrition in the surrounding tissues and thrombophlebitis. Monitor insertion site for redness, pain, swelling, and foul discharge. Monitor for elevated temperature, elevated white blood cell count, tachycardia, chills, and headache. Observe for hyperglycemia. Monitor for elevated blood glucose level, osmotic diuresis, dehydration, and metabolic acidosis. Observe for hypoglycemia. Monitor for low blood glucose level, headache, frequent yawning, sweating, disorientation, and loss of consciousness. Observe for fluid volume overload. Monitor the amount of fluid infused, as a fast drip can lead to fluid overload. Monitor for jugular venous distension, bounding pulse, increased blood pressure, and crackles on the base of the lungs on auscultation, DEWS. Flush the catheter line after infusion of parenteral nutrition regularly. The line should not be twisted or kinked. Keep a port or line dedicated for parenteral nutrition infusion. If parenteral nutrition infusion needs to be discontinued for any reason, keep the bag in refrigerator, 4 to 8 degrees Celsius, and reuse within 24 hours. Administer parenteral nutrition solution only after it comes down to room temperature. Don'ts. Never stop parenteral nutrition abruptly unless there is a complication. Don't use femoral veins for infusion. Following these practices, we can make parenteral nutrition administration safer for patients and help them recover faster.
This is a self-explanatory video. The 3-chamber bag comes with glucose, amino acid, and lipid. And once you open the outer cover after inspection, put it on a hard surface and roll it so that it will be. Always give a pressure in this side, the right hand side first, and then the left. And once the glucose amino acid mix, then you can mix it with the lipids. And then you can put the IV set, and this blue port with the arrow downward is for the IV set, and the white port with the arrow upward is for adding vitamins, minerals, and electrolytes or trace elements, not anything else. Once everything is mixed, no, you can tilt it so that it is ready for the infusion. And this is how you have to do the mixing. And then IV set, all the lines has to be discarded within 24 hours. Thank you. If you have queries, you can discuss. Otherwise, thank you very much. I think you are waiting for a long time. Thank you.
Thank you, ma'am, for the detailed and fun presentation. I request Ms. Marina E. Alex to honor Ms. Sharmila Parthiv. Thank you, ma'am. A small instruction for all of those who haven't received the certificates of the event can come near the comparing desk and collect it after the event. Now we have a small video session by Dr. Ankita.
Hello, am I audible? Hello. Hello. All right. So, hello everyone. My name is Ankita. I'm a registered dietitian, and today I will be presenting on how to apply or how to use BIA device in nephrology segment. Is the screen visible? So medical application in nephrology and how it can be much more effective when we use BIA device. We all know there is a declining kidney functions, and at every stage we need to assess the patient for the better quality of a life of an individual. So this is how, once you do the BIA test, this is how the result should look like. So within one glance, we come to know what is the dry weight of an individual, how well the person is doing the water control. At times, we give them the dietary guidelines when they're to restrict the sodium or probably to restrict water, and how efficiently they are doing it. We can come to know with the help of extracellular water ratio. At times, because of dialysis, they come across certain circulatory disorders. We can assess that, and we can also assess the severity of their condition, or else probably what we can call it as a phase angle in such individuals. This is how the result sheet will look like. So how can we come to know what is the dry weight? So in general people, the ratio between the extracellular water and total body water is 0.380. But for the patients who are on hemodialysis, the normal ratio between them will be 0.390. And this extra 0.10% is for overhydration in extracellular water. Now, how do we calculate that? Whenever the person undergoes dialysis, the extracellular water is being reduced. That is a extracellular fluid which we remove from the water from the body during the dialysis. So how can we calculate the measurements of with in body. So we get the ratios on which limb, how much water is present. For example, this is a case study. There is a normal intracellular water. We need to find out normal extracellular water. And this ratio is for normal individual. If we add, it will be 1, 0.615 plus 0.385. If we add this, it will be 1. So when we do cross multiplication, we get it as 14.59. And then we have to subtract current extracellular water ratio minus normal. And that's how we come to know what is the excessive weight or probably excessive water which is present. This is how we get our dry weight with the help of BIA technology. Dry weight is the body weight when extracellular water of in body falls in the normal range, that is 0.385 in normal individual. But for someone who is undergoing dialysis, it will be 0.390. Then if we see correlations, it's 99% correlated when we take a dry weight of the individual. Then when we see dialysis patient with diabetes or hypoalbuminemia, so this is one of the complications which we come across. So in such time, we need to consider the different water levels for this individual. So for example, for a normal patient who is just a renal patient, we'll consider normal ECW ratio, that is 0.385. For person who is having either a diabetes or hypoalbuminemia, we'll consider as 0.395. And someone who is having both, that is diabetes plus hypoalbuminemia, we will consider it as 0.405. So this is how we will come to know about their dry weight. So on the result sheet, you will get one column which talks about water control. So there are 3 types of dry weight which we get, but for 3 different conditions. One, where the person is only renal patient without diabetes and hypoalbuminemia, one with diabetes or hypoalbuminemia, and one with both. Now we need to also figure out what is the circulatory issues which are going on. When we make person, when the person is in the lying posture, ideally what happens is we'll just take in the conventional method, the whole body as one cylinder. But when we do it with advanced BIA technology, the body has been divided into 5 cylinders, that is to upper limbs, to lower limbs, and a truncal region. So we get the segmental information. Out here, if we see body water result sheet, here in this case, there is a difference between the right arm and the left arm, and right leg and the left leg. If arm extracellular water ratio is higher than leg, then what happened? So it's very essential to assess the individual based on their water levels. It also helps us to understand if the person is having any complications, that is central vein stenosis or any kind of thrombus or embolus formation which has taken place during dialysis based on this water levels. So out here, this is a case study where 52-year-old woman with diabetes, this is post hemodialysis, where the extracellular water of the left arm was 0.440, whereas right arm was less. Out here, that is 0.387. So this patient had CVS, who was about to have blood vessel transplant surgery 1 week later. So this is how we got to know there are certain complications which were developed in this individual. Out here, here before it was right arm, second case where the right arm, it was over 0.40, and here the left arm is below 0.38. So there is a huge difference between 2 limbs. But after taking preventive measure, the water level started dropping down of the right arm. Another case where initially there was very minimal difference, but later difference kept on increasing. So when on constant monitoring, the difference kept on increasing. Initially, it was 0.003, then 008, then 019. So that's how we could actually monitor CVS patients and to understand what is the difference in their water levels of that particular limbs. Secondly, we have something known as phase angle. It will tell us about the cellular status, or we will understand the aging and malnourishment in this patient. If the cell is intact, that means cell membrane is proper. So the phase angle will be on the higher side. If we talk it in a simple word, we all know what is prism. If we pass a ray of light in our prism, it will refract. Likewise, when we pass a electric current, that we call it as an impedance, through a healthier cell, it will refract and it will make multiple waves. The waves at which it will intersect, it is known as phase angle. If the cell is intact, the phase angle will be on a higher side, but if it is damaged, phase angle will decrease. Like this. So usually the phase angle for a normal individual is above 4. We call it 4 to 6 normal. Between 2 to 6, it's age related or because of chronic illness. But when the phase angle drops down below 2, that means the person is critical. We say the GC is poor. This is a case study of 82-year-old woman who was on dialysis, a long-term dialysis that was for 15 years. They had a good nutritional status because their phase angle was approximately 4. But likewise, in the 53-year-old individual, at a young age, less than 5 years of dialysis, but nutritional status was very poor. The prognosis of this patient was really poor. Then one more very essential tool which we need to understand in renal patient is whether the person is becoming sarcopenic or no. And how do we assess is with the help of skeletal muscle index. It is a marker to assess sarcopenia. It is appendicular lean mass divided by height in meter square. So for males, it should be 7 kg per meter square. If it is below that, then that particular individual is sarcopenic, and for female it is 5.7 kg per meter square. If it is below that, then the individual is sarcopenic. This is the case study. You need to add right arm plus left arm, right leg plus left leg, and divided by height in meter square. So when we get that, the answer is 4.3. So this individual is sarcopenic because the female, it is 5.7 kg per meter square. So this is the way we will assess sarcopenia. We will assess the water related or circulatory disorders with the help of water levels, and we will also assess the dry weight with the help of BIA technology, which is very crucial in the renal patients. Thank you. Hello.
Thank you so much for the wonderful presentation.
Thank you, ma'am. Thank you for having me here. Sorry I couldn't make it there, but thank you so much for this opportunity.
Thank you.
Good afternoon to all. Thank you very much for staying back, being a long day. Thank you. Thank College of Nursing, all those who are attended this conference. I hope this program would have really kindled your knowledge on nutrition. I thank you very much. Thank you all the staffs. Especially I want to thank the biomedical department, Shiva and Abby for all the support, and whomever, if I left anyone, I thank all for all the arrangements that is done towards this conference. I wish you all the best. Any other knowledge more, you have any doubts regarding the nutrition, please feel free to come to our department. We can help you out. If you want to learn more about this body composition or any other things, please feel free to approach us. All the best. Thank you, one and all. Thank you very much. 1 second.
People who have not received their certificates kindly collect it from the counter over the left side.
A great memory lasts forever, and so does great teaching. On that note, we've come to the end of the day's events, and we really hope you found all the sessions very informative. Carry home this abundant knowledge, implement the same, and work together for achieving the ultimate goal of saving lives. On behalf of the Department of Nutrition and Dietetics, I would like to thank one and all for making this show a grand success. Thank you. Jai Hind.